Yes, ma'am. Ma'am, I'm preparing for that just to get it live stream. Just
Right.
one second.
Right.
So, ma'am, we are good to go in 3, 2, 1. Ma'am, we are good to. We are live now.
Yes. Good evening, everyone. We welcome you all on behalf of Win India. We are happy to announce that we are going ahead with the establishment of the state chapters. We recently had on 14th June the inaugural start of the Win Andhra Pradesh chapter, and now we are here today with the second state chapter. Of course, Win Tamil Nadu is existing, so we have the third state chapter under the aegis of Win India going to go for inaugural as of today. Before going on to the start of the inaugural meet, I would like to take this opportunity to make a few announcements. Siddharth, can you please project? This is our 5th edition of the Win India newsletter, which has been mailed to everyone. So we are very glad that we are able to release it now. May I request the president of the Win India, along with the senior faculty, to release the Wing's 5th edition, madam. Over to Dr. Urmila and the senior faculty.
Good evening, all. I could see Dr. Vimla, Dr. Nandita, and Dr. Anuradha, madam. Thank you for all your presence. I think it's an honor for me to be part with all the 3 stalwarts to release the 5th newsletter, which is just released now, preceding our annual meeting. I'll request a few words from Dr. Vimla, Dr. Anuradha, and Dr. Nandita, and Manjari also, if possible.
Madam, this is our newsletter, madam, incorporating all the events that have been done by the Win India
It's
members.
released, and I just want him to say a few words about it.
Yes,
also.
madam, yes. Madam Anuradha, madam, Vimla, madam, and Nandita, madam.
A few words about newsletter and your thoughts on.
I think we should congratulate ourselves that we are going so fast, and it's wonderful to see this newsletter also ready. And I think hearty congratulations to all those who have been involved in this newsletter. I think mainly Dr. Swarna. So I have not gone through it as yet, but I'm sure we have articles in that. So I wish Win India all the best, and of course hoping to see you all in Win Icon 2022. I hope at least this time we'll have a chance to meet in person.
Thank you, madam. Thank you so much. Over to Dr. Vimla and Dr. Nandita.
I really wonder how you find so much of time. You are so motivated and things are going so fast. The Wings has come out very well. And I was talking to Srilata that we should follow Telangana chapter and others, Tamil Nadu, and have our own chapter. You are all motivating us. Congratulate you for the wonderful work you are doing and wish you all the best.
Thank you so much. Dr. Nandita, madam.
Yes, hello. Can
Yes,
you hear
madam.
me?
You're audible, madam. Please go ahead.
Yeah, it's a really good thing to see that you have progressed so much in 1 year or 1.5 years or 2 years. I don't know, but then the newsletter looks very good. It's great. And I really congratulate the Win India workers who are doing actively so much work in the southern and western India. We in the Northeast also are planning to form a chapter like the Telangana chapter, and we'll be informing you very soon. I'm sure the activity will go on and on, and we are really going to do something for the women in India as far as the nephrology goes. Thank you very much.
Thank you, madam. Thank you so much for the kind words from the senior faculty, and I also thank Dr. Urmila Anand for releasing the Wing's 5th issue of the newsletter of Win India. So we are also glad to share, next slide, Siddharth, we are also glad to share that we are coming up with the first annual conference of Win India, that is the Win Icon, scheduled for 13th and 14th August, Saturday and Sunday. This is about 2-day program, which starts with a pre-Congress workshop focusing on the genetics, followed by an extensive and an impressive scientific program involving the experts of national and international repute. And we request the students and the faculty to register themselves. There's a special oral paper session as well for the students. So abstract are requested to be submitted, the last date being 10 July. So I take this opportunity to request the faculty and the fraternity to pass on the information to the students as well as the fraternity to register for our own conference, the first chapter coming up in Hyderabad. And we all welcome you to Hyderabad city. This is a hybrid conference. Having said that, we request and will be more than happy to have you in person. So this is, please mark your dates. It's on August 13th and 14th. Next slide, Shrikant, Siddharth. Yeah, we're also happy to share that our WIN ICON conference has been endorsed by the International Society of Nephrology by the efforts driven by our President, Dr. Urmila Madam, and our Vice President, Dr. Manisha Sahai. So there was no issue in when we had submitted the letter. So we're very happy to share that the International Society of Nephrology has endorsed our conference. So thank you so much, everyone. Thank you, Madam. Thank you so much. So these are all the efforts that are being put in by the WIN India to make our conference to the best of its, existence. So we all go ahead as a team, and we are sure as a team we'll make it as a big success. So we request everybody to join the conference on 13th and 14th August. So with these words, I open the WIN TS chapter to be started. Over to the Mistress of Ceremonies, Dr. Anuradha.
Yes, ma'am. Good evening, madam.
Thank you.
A very good evening. I am Dr. Anuradha, Assistant Professor Nephrology, Usmania General Hospital. I extend my warm welcome to all of you. Women have contributed to a great extent to nephrology and will be contributing to do so. We, the nephrologists of Telangana and nephrologists across India, have gathered here for the inauguration of WIN India Telangana State Chapter. Let us have the pleasure of listening to the opening remarks by our President of WIN India, Dr. Urmila Anand Madam, who is a Senior Consultant Nephrologist at Amrita Hospital, Faridabad. And the moderators we have to say the session, to moderate the session, we have with us Dr. Anuradha Raman Ma'am, who is a Senior Consultant Nephrologist, Sunshine Hospital, Hyderabad. Dr. Vimala, Professor HOD, Government Medical College, Kozhikode, Kerala. Dr. Nandita Chaudhary Madam, who is a Senior Consultant Nephrologist from Assam. Over to you, madam. Ma'am, Urmila madam, kindly unmute madam.
Can I start? Yeah. Madam, Dr. Anuradha, Dr. Nandita, and Dr. Vimla, it's a proud privilege to have the three senior nephrologists as part of the inaugural session of our Telangana chapter of Women in Nephrology India. I have very few words to say because it's all just 11 months since we started our first meeting, and we have really moved forward. We have our newsletter, and I'm proud to say our journal, Indian Journal of Kidney Disease, Dr. Anupama has now signed a contract to be, this journal will be on the platform of Medno. We are having monthly regular meetings. We have had inaugural chapters of Andhra Pradesh. The Tamil Nadu chapter is already existing. And today it's a privilege of my home state. I still call Telangana my home state to inaugurate its chapter. As Manjusha says, this has all been a teamwork. Many of us, many of my colleagues have stood forward and have really given wings to this organization. My request is for the idea of WIN India was to be a very inclusive organization, and now many of us have now put our efforts. My only request is all of you from all over the country, please contribute. Please make this organization not just a successful organization, but a sustainable organization. To say a few words, I need to thank Manjusha, Manisha, Sohelata, the girls, three of them who have really made this possible. They work continuously day in and day out to make this organization such a success. And I'm so proud to be part of this organization. And the second point, which Manjusha mentioned, I would request all of you, the senior ones, to please visit Hyderabad during 13th and 14th of August for our first annual meeting. Manisha Sahai has put, I think, hours and hours together to have a very impressive program, which is, I think, 6 or 7 international speakers talking about in this meeting. I don't want to take you long from the actual scientific meeting of Telangana chapter. I wish all of you all the best, and I hope that and pray that this organization moves from strength to strength, and as all of you say, should set an example, not just to our state, but to the Indian Society of Nephrology. The vibrancy, the dynamism that has been infused in this organization by not just the girls I mentioned, there are many, time doesn't permit, who contribute. Yesterday night, we had a very successful wing chat. They're all working behind the scenes to make this organization a success. And I wish the Telangana chapter all the best. And I hope all the girls and young women who are part of it contributes continuously for this chapter. Thank you very much.
Thank you, madam. Thank you for your kind words. Now moving on to the next session. Now we have a Telangana WIN President, Dr. Kiranmai madam, who is a professor in Usmania General Hospital Department of Nephrology. She will address the session. To moderate the session, we have with us Dr. Manisha Sahai madam, who is a professor and head of the department, Usmania General Hospital, Hyderabad. Dr. Anita Saxena, professor from SGPGI, Lucknow. Dr. Swarnalata madam, professor from NIMS Hospital, Hyderabad. Over to you, madam.
Thank you, Dr. Anuradha, and thank you, Dr. Urmila and Dr. Manjusha, for the opening remarks and the pearls of wisdom given by the senior nephrologist. Dr. Anuradha, Dr. Vimla is there, and I think, yeah. Dr. Nandita, yeah, I can see Dr. Nandita there as well. So all three have been great mentors. Now coming to the program at hand today. So I welcome Dr. Kiranmai, who will be taking over as president of Telangana chapter of WIN. Dr. Kiranmai is a close friend. She is the professor of nephrology in Usmania, and we have been together for quite some years now. She did her MD Pediatrics from Nilofer Hospital and subsequently did her DM Nephrology from Andhra Medical College. And she received a gold medal in 2006, Mahesh Narayan Gold Medal for DM Nephrology. Subsequently, she has been working as faculty in Usmania General Hospital, and she has moved from assistant professorship to an associate professor and is now currently professor. She is a DM and nephrology teacher. She is a thesis guide and has been examiner for DM students as well. So as I said, very nice-hearted person, and I'm really lucky to have her as my close friend. And we discuss not only cases, but other aspects as well. And it's a great ambience in the department. Over to you, Dr. Kiranmai, for your presidential lecture. And subsequently, we can have comments from Dr. Swarnalata as well as Dr. Anita.
Thank you, Manisha. Thank you for the kind words. Thank you very much. Good evening, all. Today is a momentous day for us, Women in Nephrology. Women in Nephrology is an organization which is providing an excellent academic exchange platform for us. I'm Dr. Kiranmai, working as Professor of Nephrology at Usmania General Hospital. As a pediatric resident, I was fascinated with nephrology and pursued it. Thus started a phenomenal journey. In this journey, I could meet pioneers like Dr. Anuradha ma'am, and was fortunate to work as a colleague with Dr. Manisha, Dr. Swarnalata, and Dr. Manjusha, who have contributed to the nephrology and inspired many young women. I feel honored and privileged to be the inaugural president of WIN Telangana State. I thank Dr. Urmila ma'am and everybody who have nominated and believed in me as a president of Telangana State. WIN Telangana State has a vibrant young team which strives very hard to help the aspiring women in achieving their academic objectives. And I promise to fulfill my duties as a president, WIN Telangana State. Thank you all.
Thank you. In fact, I know Dr. Kiranmai madam much before, as I met as a nephrologist. In fact, Madam has done pediatric general medicine, like pediatric in SVMC before she joined Nidophor Hospital. Initial months, and I was a resident there. I was I was going through the house surgeonship. So I know her as a very good human being and very soft spoken. And she's, apart from a very good nephrologist, she's a very good human being. So we have to actually appreciate that part of it. So I really, admire her for that. And she has been my I can say the mentor, first mentor before I, reached Hyderabad as a nephrologist. So thank you, Madam. I think you will definitely take this nephrology win the Telangana chapter to a next level. It will be another feather to win India. And with your experience, I definitely, I'm sure this will be a role model for the other state chapters as well. Thank you, Madam. Thank you very much.
Thank you, Surna. Thank you for the kind words. Surna has been a friend and mentor in many ways. Thank you.
Dr. Anita Saxena, Madam, you want to add?
Every time we meet, every time I say it's such a dynamic association, the Win India has come up with so much of force, strength, and vigor that it is really very wonderful to see that within 11 months of time, you have the third chapter already on, and all of the, everybody looks so dynamic, and I have full faith in Dr. Kiranmai that she's going to take it further, and all of her, the entire cabinet that she has of the vice president and the general secretary and the joint secretary and all the executive members, I'm sure they must be very, very enthusiastic to take the chapter forward. And I congratulate Win India, and I congratulate Win Telangana chapter for initiating this move, and we do look forward to a lot of contribution from you and bringing and making Win India big success. Thank you,
ma'am. Thank you very much. Thank you so much.
Thank you, Madam. And moving on, we have with us Dr. Priya John, who is a consultant nephrologist at AIG Hospitals, Hyderabad. She will introduce the TS Council to the session. And to moderate the session, we have with us Dr. Manjusha Madam, who is Professor and Head Gandhi Medical College, Hyderabad. Dr. Kalpana Mehta, Professor and Head Tamil Nadu Medical College, Professor and Head TN Medical College, Mumbai. Dr. Sonal Sanjeev, Senior Consultant Nephrologist from Gujarat. Over to you, Dr. Priya.
Yeah, Sonal hasn't joined. So this is an opportunity, in fact, for us to bring this state chapter. So after Andhra Pradesh, I think Telangana has come up with a state chapter. I'm sure the team, which is going to be introduced now by our secretary, will work towards the betterment and, of course, take it to the next level and place itself on a separate, on an elite platform in the national and global platform. So over to Dr. Priya John. She is the secretary of the WIN Telangana state chapter. Over to you for introduction of the council members.
Hello, everyone. A very good evening to everybody. Thank you for joining for this inaugural meet of WIN Telangana State Council. At the outset, I would like to thank Dr. Manjusha Madam and Dr. Kiranmai Ma'am for having trust on me and giving this responsibility of secretary for this WIN TS Council. So without any further delay, I would like to start off with the members. So I think we have a dynamic group of members here in WIN TS. So we have President Dr. Kiranmai, Vice President Dr. Dhanalakshmi, General Secretary myself, and Joint Secretary Dr. Rana, and Treasurer Dr. Anuradha. So our President, she's one of the most encouraging and the friendly professor we have. She's the president of WIN TS Council. So she is presently professor in Osmania Medical College, and she has a lot of publications and publications to her credit, and she's one of the amazing and a friendly teacher to her students. And we have Vice President Dr. Dhanalakshmi, who is presently Professor, Head Department of Nephrology at ESI Super Speciality Hospitals. And Secretary, myself, I am a consultant nephrologist at AIG Hospitals. I'm part of NSMC 2022, and I'm also a member of WIN India social media team, and I tweeted Dr. Priya John. And we have Joint Secretary, Dr. Rana Fatima, who is Consultant Nephrologist in Karimnagar. And we have Treasurer Dr. K. Anuradha, who is currently Assistant Professor at Department of Nephrology, Usmania General Hospital. And the executive members are Dr. Josna, who is Senior Consultant Nephrologist at Star Hospitals, Banjara Hills, Hyderabad. And Dr. Rama, who is currently Assistant Professor in Nephrology at Usmania General Hospital. Her areas of interest include glomerular diseases, lupus nephritis, and pregnancy-associated AKI. And Dr. Bhavya, who is currently consultant nephrologist at Mamata Academy of Medical Sciences. Her interests include critical care nephrology and and the second transplants, nephrourology, pregnancy-related acute kidney injury, and glomerular diseases. And we have Dr. Deepthi, who is junior consultant nephrologist at ESI hospitals, and she's a part of member of Win India Web Portal Committee. And we have Dr. Shabana, who is presently assistant professor at Gandhi Medical College, Secunderabad. We have Dr. Lalita, who is currently consultant nephrologist at INU, Secunderabad. And we have Dr. Himadipti, who is presently consultant nephrologist at KIMS Hospital, Secunderabad, and Dr. Shushmita, who is currently consultant nephrologist at KIMS Hospital. So, and we have, I also take this opportunity to welcome women postgraduates for this year. From Usmania, we have 2 women postgraduates, Dr. Lohita and Dr. Pragya. And from Gandhi Medical College, we have Dr. Nayana and Dr. Sriniti, Dr. Snigdha. And from Nizams, we have Dr. Pallavi and Dr. Shweta. So, yeah, so I think we have one of the most vibrant members in the Wing TS Council, and with the able guidance of our president, we and with the team effort, we would try our best to promote Wing TS both at the national and the international platform. Thank you.
Yeah, I mean, Dr. Kalpana, madam.
I must first congratulate Dr. Anuradha and Dr. Manisha and the whole team, because I have not been a very active part of it because of some commitments in my hospital, but I am out of it. So I will definitely get actively involved now, and that's my commitment and promise. Must congratulate Dr. Kiranmai for this Telangana chapter, which is definitely motivating us. We will with my other colleagues in Mumbai and Maharashtra, we will definitely soon come back with this Maharashtra chapter. And thank you very much. And we can.
Thank you, ma'am. Thank you.
Thank you, madam. Thank you so much. So I think we should foresee much better developments under the spearheading of Dr. Kiranmai as well as the secretary, so that the TS win will be taken to a next level. Thank you. Thank you for the opportunity. Over to you, Dr. Anuradha.
Yeah. Now, without any undue delay, let us move on to the academic piece. Our academic session begins with Dr. Nayana, who will be presenting AKI paraquat poisoning. To chair the session, we have with us Dr. Renuka Madam, who is a professor and head from St. John's Hospital, Bangalore. Dr. Arpana Iyengar Madam, who is a professor pediatric nephrology from St. John's, Bangalore. And Dr. Manisha Dasi, consultant nephrologist from Delhi. Over to you, Nayan.
Can you please bring slideshow mode, Dr. Nayana?
Slideshow.
If it's okay, or we can go ahead with the same mode.
Is it okay, madam? Visible, ma'am?
Slideshow mode, slideshow, is it possible or not? You can
I am on my slideshow mode, ma'am.
Dr. Nana, ma'am, you just unshare the screen, again reshare, and instead of slide, you select the screen. Ma'am, then I think your
no
slide
issue. I think Siddharth, it's okay. You see, unshared. Okay, right. Perfect. Please go ahead.
Good evening, one and all. I am Dr. Nayana, doing my first year nephro residency in Gandhi Medical College. I am presenting paracut poisoning, acute kidney injury, experience from a tertiary care center. Paracut is a toxic bipyridyl compound, which is also known as methyl violagen. Herbicidal properties were actually discovered in the early 1950s by Imperial Chemical Industries Lab at Jaylots Hill, Berkshire, England, and it was first manufactured and sold under the trade name Gramoxone as a non-selective quick-acting pesticide in 1962. Globally, paracut is the second highest selling weed killer. Commonly used pesticide in developing nations as it is cheap and it is extremely toxic when ingested. It has a protracted clinical course and no known antidote. The case fatality rate accounts to 70% internationally, and even a minimal ingestion of 10 to 20 ml, about a mouthful, is noted to be lethal, that is 20% paracut. The mechanism of injury of paracut is the toxicity is created by through redox cycling mechanism, that is repeated reduction and oxidation mechanism, where it produces free radicals, superoxide anions, and singlet oxygen, which will be depleting the cellular NADPH and ultimately causing lipid peroxidation and cell membrane damage. And this results in the multi-organ dysfunction. Basically, paracut will be interfering with the electron transport system in our body. The main target organ damage is lung, followed by kidney. In lung, since paracut has a structure which is very similar to that of the polyamine, it gets easily accumulated in the alveolar cells, both type 1 and type 2. And this results in diffuse alveolitis, and which can result in pulmonary fibrosis over 1 to 2 weeks in case of severe poisoning. And in kidney, it predominantly accumulates in proximal tubular cells, where it causes vacuolation and resulting in renal tubular necrosis. In liver, it results in mitochondrial damage and endoplasmic reticulum degranulation. This gives us an idea about how the amount intaken, like less than 20 mg per kg, 20 to 40 mg per kg, and more than 40 mg per kg, resulting in mild, moderate, and permanent poisoning. In mild poisoning, generally the symptoms are usually having mild GI symptoms, minimal pulmonary and renal involvement, and usually results in complete recovery. Whereas in moderate poisoning, which is seen when intake is about 20 to 40 mg per kg, where the immediate symptoms are usually GI symptoms of vomiting, and within hours, patient develop diarrhea, abdominal pain, oral ulcers, and over days results in renal failure, hepatic impairment, hypertension, tachycardia, and over weeks results in pulmonary fibrosis. Survival is possible, but death usually can result in over 2 to 3 weeks, predominantly due to lung failure, respiratory failure. And in case of fulminant poisoning, which is due to intake of more than 40 mg per kg body weight poison, where the immediate symptoms will be again GI, which include vomiting, diarrhea, abdominal pain, renal failure develops over hours to days with hepatic impairment, GI ulceration, pancreatitis, myocarditis, refractory hypertension, and coma. Survival is extremely difficult and death occurs within first 4 days. Diagnosis of paracut poisoning is mainly with the help of the presence of circumstantial history regarding the occupation of the victim, and mainly agriculture, regarding the exposure of the present poison. And also we check for the routine parameters of the complete blood picture, renal function, liver function, electrolytes, and arterial blood gas analysis, and also chest X-ray. And qualitative assessment of poison is mainly assessed with plasma and urine dithionate test. Which in the presence of an alkaline medium, this dithionate agent actually will be reducing paracut, thereby producing blue colored radicals. And it is produced in presence of based on the amount of concentration of paraquat in plasma and urine. If in urine it is more than 1 milligram per liter, and in case of plasma, the paraquat level is more than 2 milligram per liter, this turns out to be positive, which helps in assessing qualitatively and also is a prognostic indicator. The treatment protocols include gastric lavage with saline followed by 1 gram per kg activated charcoal and cathartic agent like magnesium citrate. The other protocol is using charcoal hemoperfusion when the urine paraquat concentration is more than 5 milligram per liter, which can even be repeated if the persistent urine concentration is more than 5 milligram. Then there's pulsed therapies of cyclophosphamide of 15 mg per kg, which is given over for 2 days with pulsed methylpred 1 gram per day for 3 days, followed by giving IV dexamethasone of 20 milligram per day for 11 days. And if the PaO2 is below 60 millimeter mercury and the duration of illness is persisting for more than 2 weeks, and the initial therapy has been given with pulsed dose and that has been completed 2 weeks back, we can even repeat the pulse therapy of cyclophosphamide and methylpred. Then it is always essential to give normal oxygen therapy, that is with the FiO2 of 21%, because the oxygen therapy itself can induce oxidative stress, which in turn can produce free radicals and oxidative superoxide anions, which can further worsen the respiratory situation of the patient. Then the other antioxidants like N-acetylcysteine, which will be repleting the glutathione, which acts as an antioxidant. Similar mechanism for both vitamin C as well as vitamin E. So regarding the GI decontamination, which we give with the help of gastric lavage followed by activated charcoal, which usually has to be initiated within 1 hour of paraquat ingestion, maximum of 4 hours. But studies mainly by Edelston et al., which was published in Lancet, which is an RCT done in 2008, which showed that there was no clinical benefit with the GI decontamination procedure. Then regarding the role of charcoal hemoperfusion, Liang et al. Published a study in 2018 to check of the efficacy of activated charcoal hemoperfusion on renal function in patients with paraquat poisoning, which found that the elimination kinetics of paraquat by kidneys were only associated with serum plasma paraquat concentration in patients with normal renal function. And therefore, in case of severe paraquat poisoning, activated charcoal hemoperfusion had very little effect in avoiding acute kidney injury. The next study was by Hsu et al. In 2012, which was actually an old study, which showed that early hemoperfusion, if initiated, can improve the survival of severely poisoned patients, provided these patients were already treated with the repeated pulsed immunomodulatory therapies. Next, regarding the role of CRRT, Gavo et al. Published a study at the International Medical Research in 2015 on early hemoperfusion with continuous veno-venous hemofiltration to assess the survival improvement in paraquat poisoned patients. And the conclusion was that combined therapy with hemoperfusion and continuous veno-venous hemofiltration was possible to prevent early death and prolong survival duration following acute paraquat poisoning. Similarly, in BMC Pharmac and Toxicology, Fang Li et al. Published a study of influence of strengthened hemoperfusion combined with continuous veno-venous hemofiltration, which also revealed the same study, same conclusion that there was a good improvement in the survival rate on follow-up of up to 90 days. Post-discharge from the hospital, where these patients were treated with strengthened hemoperfusion with continuous veno-venous hemofiltration. And similarly, a prospective controlled trial done by Chang Li et al. Also revealed that there is an excellent improvement in the survival rate when combined therapy of CVVH and hemoperfusion was being given in acute paraquat. And coming to the global and Indian scenario, in global scenario, nearly 32 nations have already banned paraquat, especially Brazil, Syria, Kuwait, Sweden, Denmark, Malaysia, Switzerland, where there had been increased mortality with the use of paraquat, as well as in 2011 studies have showed paraquat as a causative agent for Parkinson's disease in the agricultural workers in these places. Hence, the use of paraquat was banned in nations. This was actually a joint Indian study which was published in our country, stating the following results, where paraquat dichloride was found to be used in 25 crops in our country, whereas it is approved only for 9 crops by the Central Insecticide Board and Registration Committee, which was in violation of the Indian Insecticide Act. The manufacturers have recommended the use of paraquat for crops other than those approved by the Central Insecticide Board and Registration Committee, which was clearly illegal and violation of the Indian Insecticide Act by the manufacturers. Often, our farmers and workers do not read or understand the label on the paraquat container and instruction leaflet properly. They normally follow oral instructions of the dealers and retailers and their field staffs. And they are often being sold in plastic carry bags and refill bottles, which is again a violation of the Insecticide Act. And most of the farmers are not educated, they are not trained regarding use of the personal protective equipments. And often this paraquat is being mixed with additives like kerosene and other fertilizers. And these all can cause toxic effects on the agricultural farmers. And this study actually showed the mortality rate of 42 to 80% in our country. And Kerala has banned this herbicide in 2011. Why do we conduct this study? Even though paraquat is an extensively used pesticide in our country, data on poisoning are limited to very small case series and reports. So this study is mainly to understand the clinical features and outcomes, including those following renal injury. We did a retrospective case record-based study of patients with paraquat poisoning admitted medical ICU over a period of 3 years. Those with inadequate medical records, pre-existing respiratory, liver, and kidney diseases were excluded from this study. Clinical presentation and laboratory data were analyzed to study the risk factors associated with mortality and morbidity. All the patients were managed with gastric lavage, N-acetylcysteine, IV methylpred, vitamin C, and 20% of them received IV cyclophosphamide. Now moving on to our results, total patients included in our study were 100, of which 12 of them had incomplete case record. The mean age was 28.4 plus or minus 10.6 years. 76.1% were males, and the mode of poisoning was predominantly suicidal. That accounts to about 90.9%. Moving on to the clinical presentations, about 51.1% of them presented with vomiting, followed by oral ulcers. And 25% of them had breathlessness, and 19.3% of them had oliguria. The mean amount consumed accounts to 60.8 ml plus or minus 34.5. The latent time to referral was about 6 days, and total duration of hospital stay was approximately 14.4 plus or minus 4.8 days. With respect to urine output, only 14.8% of them had anuria, and about 58% of them had non-oliguric renal dysfunction. Now, going on to our lab parameters, hemoglobin, the mean value was 11.4 plus or minus 1.7. Potassium of Hello.
Yes, Dr. Naina. Dr. Naina.
Hello.
Yeah, you're audible, Dr. Naina. Please go ahead. Start sharing. Yeah. Screen is visible. Please go ahead.
Serum creatinine at admission was 6.8 plus or minus 3.1 and bicarb of 13.5. And regarding the LFTs, SGUT and SGPT was in the range of hundreds and anion gap of 14.9. Uh, 68.2% of them had nil urine albumin and only 8% of them had proteinuria. And among our patients, 79 of them underwent hemodialysis and 3 to peritoneal dialysis and 3 for CRRT. And those with other organ involvement, 31.8% of them had one organ involvement, either liver or lung, and 38.6% combined 2 organ involvement, and about 50% of them required ventilator support. And so, regarding the outcome and cause of death, 69.3% expired in our study, and the most common cause of our death was modes, which account about 42.6, followed by respiratory failure, which accounts to 32.8%. Factors causing mortality include the amount of paraquat consumed, which was about 70 ml in patients who were expired, the latent time to referral, which was about 6 days, total duration of hospital stay of 14 days, serum creatinine at admission of 7 milligram, and those with lower urine output and increased duration of renal replacement therapy. And regarding the type of, based on the modalities of renal replacement therapies, more patients of us actually underwent hemodialysis. Of them, 56 people expired, and peritoneal dialysis, 3 of them expired, and CRRT 2. And regarding ventilator, among the 44 patients who were in ventilator support, 41 of them expired. And regarding our CRRT data, we recently started CRRT for our patients. And during our study, we had 3 patients, and we had one more patient recently. Among our 4 patients, 2 recovered. 1 had renal recovery, but expired due to ARDS, and 1 died. So paraquat is being widely used as a herbicide in developing nations. Hence, it remains as a major cause of mortality among patients with acute poisoning. Majority of patients develop acute kidney injury requiring renal replacement therapy, and most common cause of mortality being multi-organ dysfunction. And on comparison with other studies, our study sample size was 100 with mortality rate of 69.3 and AKI incidence of 81.3. And Ravichandran et al., who conducted study at Jipmer Pondicherry, had 92% AKI incidence rate and mortality of 72.7. And Rao et al., who conducted the study in 2017 at Manipal Hospital, Karnataka, the mortality rate was 61.4 and AKI incidence of 88%. And similarly, in Korean studies by Seok et al., the AKI incidence was about 100%. And Moon et al. And Kem et al., who conducted study at 134 and 247 patients, the mortality rate was 73.9 and 42.9 respectively. So concluding, paraquat poisoning constitute about 6.26% of the AKI referrals in our hospital. However, AKI is present in 81.3% of our paraquat patients. Majority of our patients are in 3rd decade and are agricultural workers. Multi-organ dysfunction is the most common cause of mortality. Higher amount of consumption of poison, increased latency to referral, higher creatinine, reduced urine output, and longer duration of hospital stay were all associated with increased rate of mortality. Our study limitations include being a retrospective and single center study. The inherent biases were present and all the AKIs may not be referred to us. Some of the patients had incomplete case records and there is lack of follow-up. And also we couldn't measure the serum and urine levels of paraquat. So it's high time that paraquat has to be banned in view of its extreme high mortality rate and toxicity. Thank you.
Over to the chairpersons, Anuradha. You can invite the chairpersons with the comments.
Yes, ma'am. Yes, ma'am. So we have Arpana Iyengar, ma'am, and we have Renuka Satish, madam, professor and head from St. John's Hospital, Bangalore. Dr. Arpana Iyengar, ma'am, who is a pediatric nephrologist from St. John's, Bangalore. And Dr. Manisha Dasi, senior consultant nephrologist from Delhi.
Hello, I am audible?
Yes, ma'am.
Yes, ma'am.
Yeah.
Yes, ma'am.
Yeah, I congratulate Naina for a good presentation. I know it's very difficult to collect a retrospective data, and many of the time the records will not be complete, and it is very difficult to find out whether it is a paraquat poison or any other poison, because paraquat poison generally we don't have any laboratory this thing to confirm that it is a paraquat. So collecting such data is very difficult, and I congratulate her for collecting a nice data. And as she said, there are some data from South India as well as from Rajasthan and North India, and they are very limited number of patients, and the mortality and acute kidney injury is very high because this is mostly used in the rural setting, and by the time the patient reaches the tertiary care center, it's already a lot of time gap, and treating such patient becomes difficult. If they come early, I think that is useful. Okay, and then I also want to at this time to congratulate the Telangana chapter for its inception, and I am very surprised to see there are so many lady doctors in Telangana also from the nephrology field, and so many of them are also pursuing nephrology DM DNB from Telangana. So eventually I think nephrology will be dominated by women. I hand over to Arpana Iyengar for her comments.
Thank you, ma'am. Very well done, Dr. Naina. And as madam was saying, it's nice to see such good data presented. And I hope that this will now get translated to a publication, because we really need such evidence-based papers in India. Dr. Naina, I just had one question. Among the various factors that you studied, what do you think actually predicted AKI? You said there are factors that predicted mortality, but did you find specific factors that predict AKI in these patients?
Dr. Arpana, can I step in? So
Yes,
it's
yes.
our study. Yeah. See, actually, when the patients were referred to us, in fact, the creatinine was raised. It's not that the patients were referred to us as soon as they had a consumption of paraquat, at which time we can intervene and do some modality of extracorporeal therapy and look for the follow-up whether they're going to develop AKI. So that definitely was a limitation, because generally the poisons are admitted in internal medicine. So unless the creatinine rises, even at this time, I want to submit the limitation, because a mild rise in creatinine, they may not refer to us. So we still do not know the KDIGO of stage 1, stage 2, though 3 were in number. Unless the creatinine is high and oligonuria is present, they're not referred to us. So definitely that's a limitation. So we could not look into the aspect of prediction of AKI, since the referral pattern was little different in our study.
Well said. I think we all experience the same. As in children, we don't fortunately see too many, but we do see in adolescent kids. And then, as you said, they come quite late. And so we have missed the window period for even, early intervention. In terms of monitoring the urine test, screening test, the sodium dithionate, is this available? Anybody has, do you have this facility?
No, I don't think we have, but at national level, I think the center which we try to inquire, I don't think that's also doing. But anybody in the platform can share their opinion, because I think we have reasonably highest number of cases when we had looked into the literature. So having about 100 cases isn't a small issue. Yeah, when we try to look into that, the definitive confirmation, though most of the times it is like the history from the attendant that they had consumed this particular paraquat. I think our resident has projected that it is 70 ml and 30 ml. I think that's wrong. They generally take it with either alcohol or some cool drink or something like that. That volume is generally set as 70, 38 ml. Otherwise, it's just 15 to 20 ml itself is supposed to be toxic. So confirmation definitely isn't a very easy task, especially in our settings. But I think having said that, I think we will definitely go ahead for further trying to look into that aspect as well. And of course, from the treatment perspective, I think we have been doing hemodialysis for all the patients unless the hemodynamics are compromised. But with the recent availability of the CRRT and the governmental scheme, we have started CRRT. Little rosy picture we have with CRRT that, out of 4 patients, 3 had good renal recovery and 2 survived. Of course, 1 we lost. Again, all these factors depend on the amount, just not the amount, the latency at which they reach the tertiary care for the particular treatment. These all are crucial for us.
True. And charcoal hemoperfusion, is that something that
Charcoal
I don't think many of
hemoperfusion,
us have that opportunity to use charcoal.
Actually, literature says that unless you do it in 2 to 4 hours, because the plasma level of paraquat is very important for us when we try to look into the elimination of it, because it goes and gets accumulated in lungs and other organs. So before that, we should be able to remove the paraquat from the plasma level. So doing charcoal hemoperfusion in the first 2 to 4 hours, according to literature, apparently is supposed to be beneficial. But one or other hospitals have shared their experience saying that within 24 hours of admission also they have done HP. But in our experience, we were not able to do the HP because of the resources. Not just the resources, they reach the hospital, latency is about 4 days. So with the literature support, I don't think we should subject them for the charcoal hemoperfusion. So we are straight away going ahead with CRRTs and hemodialysis depending on the involvement and for removal. But at the same time, what I would like to submit is the medicine department should be able to refer other paraquat poisonings as well, so that if prevention of the multi-organ involvement can be done rather than treating after the onset of the multi-organ involvement.
Thank you. Dr. Manisha, please.
Sorry. So just wanted to share, we did do a couple of charcoal hemoperfusions thanks to one of the pharma companies who supplied the filters. The problem is platelets get adsorbed and thrombocytopenia is a significant problem. The cost is way too high. And you have this National Poison Informatics Center located at AIIMS, New Delhi. The number is 1800-116-117. So any information pertinent to poison, they are available open 24/7. And some of the tests are available there. So if you want, you can contact them as well. Thank you.
Can I give a small comment?
Yes, madam. Please.
Yes, madam, please. Most of these paraquat poisonings come to government hospitals. So when we were there, we have done charcoal hemoperfusion. Those days, the cartridge would be available for 10,000 or 11,000. It used to come from Chennai. But we used to do it in series with hemodialysis. CRRT was not available those days, but just hemoperfusion we wouldn't do. We would also do it in series and combine it with hemodialysis. But as everyone has said, although they seem to be recovering from AKI, the death is, most of them land in severe pulmonary fibrosis. And most of them will take a lethal dose and come. Like Manjusha has said, more than 15 to 20 ml is enough. And we know the mortality is poor, but nevertheless, we have tried this combination. We have never done hemoperfusion alone, but we have done it in series with hemodialysis.
I would like to congratulate Dr. Naina. That was an amazing presentation. A very high mortality. It makes it imperative that the weedicide be banned, or if at all it is to be used, it be used with regulation, proper regulation. I would agree with Anuradha ma'am. We have also used charcoal hemoperfusion in series with hemodialysis and with CRRT. But as ma'am has already pointed out, such patients generally land in a government setup. I work in a tertiary care center which is away from proper agriculture area. So the patients get referred to us pretty late. So using these filters hasn't really helped us, but maybe when it is used timely, it might be of some use. I would want to ask one question to Dr. Naina. There were 3 patients who required peritoneal dialysis. Was that acute peritoneal dialysis? Are you using that in resource poor setting in such patients?
It is acute peritoneal dialysis, Manisha. We don't do CAPDs for soft catheter. We don't place. We do this rigid catheter placement, and this is definitely preferred in patients who are hemodynamically unstable. So, I mean, definitely 3 patients having hemodynamic instability is little surprising, taking the multi-organ involvement into consideration. But we could do hemodialysis as well as SLEX in case of little compromise of BP. Otherwise, in lower BPs, we could do PDs. So that's acute PD, whatever we have done.
The second part was Dr. Naina also mentioned about the use of cyclophosphamide and steroid pulses. Is this actually done? Are we targeting alveolitis here with these drugs?
Yes,
I'm not
yes.
so
This actually is a treatment set up by the internal medicine teams. So before even they refer to us in order to address the fibrosis setting, because an increase in instance of release of all the inflammatory markers, this is basically to reduce the inflammation. That is the only intention of hiking the steroids or the cyclophosphamide. They have their own strategies of giving the cyclophosphamide. Not many patients have received cyclophosphamide even in our study. I think it's about 20 patients or something like that. Recently, they've started using that, but really, fingers crossed, I'm really not sure what's going to be the benefit, or it is going to be counterproductive.
Just a quick
Thank you so much.
I'd like to ask.
Madam. Yes, madam.
This 30% survivors, now the kidney failure, whatever in them, was it complete recovery?
Madam, yes, madam. Partial, yeah, Naina, please. Yeah, madam, this actually, I wouldn't say complete recovery, because by the time they got discharged, mild renal dysfunction was there. So the limitation in our study, we don't have a 30-day or 28-day or a 90-day follow-up. So it is once they are discharged from the hospital, not that patients had a complete renal recovery, madam. Mild renal dysfunction was always persisting. So we really do not know how many patients are going to land up in CKD, as we are not having follow-up of this group.
And this pulmonary fibrosis was really bad, like we saw in cases of COVID, like those who really survived.
Madam, these patients are always in ventilator, madam, because if the lung involvement is significant, CPAP, and in our setting to shift them to CT and get the lung involvement done, definitely it's a Herculean task. So I don't think in all the patients, the assessment of pulmonary fibrosis was done. But having said that, one interesting observation that we had amongst these 100 patients, 2 patients were HIV patients who had consumed paraquat. And to our surprise, both the HIV patients did not have lung involvement and recovered very well, which was basically explained based on decreased leukocyte infiltration into the lungs. And so their lung involvement is less, and they had come out very well. I mean, these 2 patients have received PD. Amongst the 3 patients of PD, 2 are HIV patients whom we had treated. So that is an interesting observation. Not much of a literature about that, HIV with paraquat poisoning.
Thank you.
Good evening.
Yeah, there are certain regulations that have been set up by Indian government as well, that only few crops need to be using paraquat, and the mode of use, the precautions, like the way we wear PPE, all these things have been emphasized. But then the advocacy of such usage is not there amongst the agriculture worker population. So that's the reason why. And of course, the suicidal tendencies, which we have noticed an increase in number post-COVID because of the financial constraints, financial debts or whatever, there is a slight increase in the number of the COVID poisoning, suicidal tendencies after the COVID. Yeah, Rana.
Good evening, madam. Good evening, everybody. I just want to add a few points regarding Dr. Naina's presentation. I work in a center which is a rural tertiary care center. So my comment is the time factor is not there when I'm receiving such cases. The main factor here is the dose, the amount, amount the patient is taking, the amount of poison the patient is taking. And it is so common here in this rural center, weekly once we are having 2 to 3 cases coming of this paraquat poisoning. And I agree with that. She has put the PowerPoint, that slide, the 100% patients are developing AKI. It depends on which, my observation is over the last 3 years. So we are also going to do a study on that. So which patients are able to come out of this crisis? Which patient are going to there are two phases in this patient. The patient dies immediately within few hours with type 1 respiratory failure and AKI 70 is happening, or the patient, the death is delayed by 1 week, 2 weeks, or 3 weeks. Almost all patients who are surviving the initial 48 to 72 hour crisis are developing AKI. It is 100% AKI. So medicine people are referring to us on day one, on the time of the patient receiving ER, we are getting a nephrology consultation. So here we are following somewhat like similar to what Dr. Anuradha had said. See, we are having HDF here. So even though there is not much data, but every patient is given a trial of HDF. So there are two indications for nephrology consultation. First is to remove the toxin, and after 72 hours or after a few days, if the patient is developing AKI 18, again we come into picture. Daily a consultation is put for nephrology people. So we are part of this care of the patient. And one thing which I noticed is, it is so common, Dr. Manjusha, if any patient is having, like in COVID time, Madam said about COVID, now it's same like COVID only. Any patient having unexplained, a previously healthy person coming to ER with unexplained organ injury, particularly type 1 respiratory failure, I ask the patient to open the mouth. I'm sorry to say that, but that's how it is. And when you see oral ulceration, completely inflamed tongue, it is almost 100%, because some few patients refuse that they have taken this poison. And over a period of time, these patients develop the typical type 1 respiratory failure and kidney injury. The patients who have recovered, I noticed, are mostly young men who have taken less amount, and they had this residual kidney injury. They had, but over a period of weeks to months, there was complete recovery. So the amount is most important rather than the time, I feel. Even though they're coming earlier, within hours also, we are doing HDF. And again, we are starting all those protocols like cyclophosphamide, steroid. The baseline is the amount of toxin which the patient is taking.
Yeah, completely agree, Rana, with your experience. I think you'll be having nearest and first-hand experience, because we will be second-hand experience in all this.
This patient.
Absolutely, completely agree with you. Yes. In our study as well, as you said, it is the latency as well as the amount. Of course, the amount was even more, significantly more in the death patients compared to the recovery patients. And yeah, we have started using CRRT nowadays, but we really do not have a significant data to support, yes, CRRT is going to benefit compared to HD alone. And of course, HP, maybe it's useful in your setup because they reach you early. And of course, we're also trying to advocate the medicine department to refer to us as soon as the paraquat comes. It's not a very high in number. It's about 148 over the last 3-year period that we had the paraquats, out of which about 100 had an AKI. And the mild AKI, of course, was not referred to us. But at the same time, we are also focusing on the removal. So we are trying to advocate the same to our medicine department as well. So thanks for your inputs, Rana. I think that's the first-hand information that we can get from a rural tertiary care center. Thanks, Rana, for so much of information. Over to the chairpersons for further comments. Yeah, over to Anuradha. Yeah, please, Anuradha.
Yeah. If there are no further questions, we'll move to the next interesting session. Dr. Kajari, a senior resident from Osmania, will be presenting on genetics in kidney disease. To moderate the session, we have Shruti Madam, who's a senior consultant nephrologist from Mumbai, Dr. Manjuri Sharma, Government Medical College, Assam, Dr. Shaista Hussain, senior consultant nephrologist, Care Hospital, Nampally. Over to the chairpersons.
Yeah, good evening. Am I visible?
Yes, ma'am.
Yes, ma'am. So, I don't know why I have.
Please go ahead, madam.
Yeah. So, good evening, all. I welcome you all for this session, Genetics and Kidney Disease. As we all know that from the past 1 decade, a lot of progress has been made on genetic basis of not only understanding the basic kidney function, but also the diseases of the kidney. We all know that there are nearly 600 genes have been identified as a monogenic kidney disease, and similarly more than 50% for non-diabetic kidney disease. Genetic information has not only given the nephrologists a better understanding about the clinical presentation of the nephropathies, as well as proper patient care, family counseling, and surveillance. So what lies ahead and how we have to, what is the way forward? I will invite now Dr. Kajari Giri for her presentation.
Thank you, madam. I've started screen sharing, madam. Is it visible?
Yeah, it's visible, Kajari. You can go ahead.
Okay, madam. Thank you. A very good evening to my respected teachers and fellow colleagues. Firstly, I would like to congratulate Dr. Nayana for her excellent talk on paraquat poisoning. And I would like to thank the organizers of WIN committee for inviting me in this and for allowing me the opportunity for speaking in this platform. I would like to present a study done on 50 patients from Osmania General Hospital on genetics and nephrology. And before going to this study, I would like to have a short discussion on the importance and implications of genetics on day-to-day nephrology practice. Coming to a short discussion on natural history of nephrotic syndrome, as we all know, 80 to 85% of the patients of nephrotic syndrome are steroid sensitive, of which 30 to 50% have infrequent relapses, 20 to 30% are frequent relapses, and also 20 to 30% are steroid dependent. Of them, 15 to 20% of the patients can also present as steroid resistance, and 3 to 6% of the patients from this group can also present as steroid resistance. Coming to the broad phenotypes of nephrotic syndrome, there may be broadly three categories. A subset of population of steroid responsive patients can present as multiple relapsing courses where steroid sparing immunosuppressants are used, but they have no history of renal failure. In these patients, immune dysfunction is postulated to be a cause behind it. Coming to the steroid resistant group, there may be two subset of patients. In one set, the patients may present as initial or late steroid resistance with variable response to immunotherapy, with high recurrence after transplant and rapid progression to ESRD. And in these patients, the presence of circulating factors is postulated to be a cause. In the second subset of patients, initial steroid resistance is a feature with no response to immunotherapy, and however they have low recurrence after transplant, and family history is often found in this subset of patients. A primary defect in podocytes is often found to be a cause behind this subset of patients. Coming to the discovery of nephrin gene variants in the late 90s have revolutionized the concept of genetics and nephrology, as it has brought podocyte and filtration barrier into focus, and it has connected molecular genetics to podocyte biology. Since the discovery of nephrin genes, more than 60 genes have been discovered till date, and they have two types of inheritance mode. It may be autosomal recessive, as in NPHS1, NPHS2, WT1, PLC1, or SCARB2 or LAMB2 genes. Also, it may be autosomal dominant, as in TRPC6, WT1, ACTHN4, or INFB2 genes. Few genes like LMX1B or LAMB2 are responsible for syndromic causes of nephrotic syndrome. Coming to a connection of genetics biology with the SRNS, genes associated with SRNS codes for podocyte structural protein and signaling pathway proteins, and they may be situated in one of the four locations. It may be intranuclear, like WT1 LMX1B genes, or it may be the actin cytoskeleton proteins, like the RCAP24, ACTN4, MyoE1, or ANLN genes. It may be in the slit diaphragm, like in the TRPC6, NPHS2, or CD2AP genes, or lastly in the mitochondrial region, like in COQ2, COQ6, PDSS2 genes. However, the most common pathway to injury is actin cytoskeleton disruption, leading to effacement and irreversible podocyte injury. Some of the genes involved in metabolism, like mitochondrial pathway, they are also amenable to treatment. Coming to the genetics in CKD, it is a gray area and not much studies has been done in CKD, as contrary to many studies have been done in nephrotic syndrome. However, the discovery of the APOL1 gene variant has been shown to be associated with increased rate of ESRD in many subgroup of patients. Of them, it is associated with 5 times increased risk of ESRD in patients of lupus with collapsing features, more than 17 times risk of ESRD in focal segmental glomerular sclerosis, or 89 times increased risk of ESRD in HIV-associated nephropathy in Africa. Besides this gene, there are other various genes have also been discovered, like in CACUT, we have found WFS1, PTPN11, JAG1 or HNF1 beta genes. In cystic kidney disease or ciliopathy, we have found NPHP3, or besides common genes like NPHP1 and NPHP2. Tubulointerstitial diseases, we have found WKN4, SCL3A1 and 3A4 genes, and other glomerulopathy genes have been already discussed before. So now the question is how to test for these genes and which modality of genetic testing to order. If a patient has a clear-cut phenotype or syndromic features are present, like if a child with nephrotic syndrome has dysplastic nails or absent patella or any presence of glaucoma, in clinical examination, we can suspect as nail patella syndrome, and we can order for LMX1B gene testing, and we can go for Sanger sequencing. Otherwise, other tests are target PCR like restriction fragment length polymorphism test if we want to go for single gene or few gene mutations. However, if the patient does not have a clear-cut phenotype, and we can test for multiple genes like target resequencing, clinical exome panel, whole genome analysis, or whole exome analysis. Now, again, how to choose a genetic testing method. If the patient, as I discussed earlier, has a classical phenotype or syndromic features, we can order for Sanger testing, or if the patient is non-syndromic, we can advise for multi-gene or NGS panel testing, and subsequently whole exome sequencing if there is no yield. Otherwise, if patients are only pediatric CKD or CKD with only proteinuria, we can advise for clinical exome sequencing directly. Now, do we test for every children or every patients in OPD? The answer is no. There are certain clinical aspects that suggest a monogenic form of nephrotic syndrome. Of them are the congenital nephrotic syndrome, younger age at onset, family history of nephrotic syndrome or consanguinity, syndromic nephrotic syndrome, presence of extrarenal features on clinical examination, diffuse mesangial sclerosis or FSGS in histology, and initial resistance of steroids are some of the important clinical markers. Coming to an important concept of genetic reclassification and reverse phenotyping, few diseases are present which are phenomimics or phenocopies of nephrotic syndrome or SRNS cases, like Alport syndrome, which is found due to mutation in gene collagen 4A3, A4, A5, dense disease due to mutation of gene CLCN5, cystinosis due to mutation in gene CTNS. Genetic diagnosis helps to pinpoint this patient and separate them from the SRNS group. Coming to the rationale of recommending genetic testing in children with SRNS, as I have discussed earlier, it helps in pinpointing molecular diagnosis and subsequently help in planning, evaluation, and monitoring of these patients. Since SRNS is a disease with various genetic heterogeneity and phenotypic variability, it also helps to identify SRNS mimics or phenocopies. Regarding the prognosis, we can inform the patient and the family about the probable therapeutic unresponsiveness, and also can prepare them for future need of renal replacement therapy. Coming to the treatment decisions, aggressive immunosuppressive therapies can be avoided in these patients, and specific treatment of COQ or CUBN mutations are also available. Coming to the transplant outcome and donor selection, we can counsel the patient and the family about the risks of recurrences, and also it helps to identify a safe live donor potential candidate. And regarding antenatal counseling and diagnosis, we can predict risk and cause fatal diagnosis. Also, pre-implantation genetic counseling is also emerging its way. Coming to the outcome, the children with genetic cause of SRNS have a poor renal outcome, as studies shows that 10-year ESRD-free survival is 94% in complete remission patients. It is 72% in children with partial remission. However, it is 43% in non-responders, and even low, that is 27% in children with genetic diagnosis. Coming to the genetic testing and transplant in SRNS, we can discuss about the recurrence risk, like it is less than 5% in genetic patients versus 40 to 50% in non-genetic patients. Coming to the donor evaluation, heterozygous carrier of autosomal recessive gene variants can safely donate. However, we should screen for a specific variant called R229Q variant, which may develop proteinuria and nephrotic syndrome even in late adulthood. Heterozygous carrier of autosomal dominant gene variant like TRPC6, INF2, ACTN4 could be avoided as a donor. Coming to the introduction of this study, the genetics is kidney disease. As I have discussed, it has undergone explosive growth in recent years due to the feasibility and availability of recent advances in sequencing technology and genetics methodology. Various studies suggest that around 10% of adult ESKD or 30% of pediatric population have identifiable genetic kidney disease. And the exons, which are the protein encoding regions of the genes that make up only 1% of the whole genome, known as the exome, they are estimated to carry at least 85% of the disease-causing variants. Coming to the methods and materials, this study was an observational study done with an objective to assess the diagnostic utility of targeted NGS in a selected population, both adult as well as pediatric, presenting in Osmania General Hospital. This study was approved by Ethical Committee of Osmania Medical College. Patients who have high index of suspicion were included. Among them, among the nephrotic syndrome cases, patients with positive family history, patients having syndromic features or congenital onset of renal disease, steroid-resistant nephrotic syndromes were selected. And among adult patients of CKD, patients with unknown etiology, positive family history, early onset or atypical presentations were selected. Written and informed consent was taken from all patients. History and demographic data were collected. Blood samples were collected from patients and genomic DNA were extracted. The NGS or targeted gene sequencing was performed. The genetic pattern of nephrotic syndrome gene consisted of 60 genes. However, in the polycystic kidney disease gene panels consisted of 6 genes and hemolytic uremic syndrome gene panels consisted of 40 genes. Coming to the gene mutations, they were classified as per American College of Medical Genetics classification into pathogenic, likely pathogenic, uncertain variant, likely benign, and benign subtypes. Coming to the results of this study, the majority of this study population, that is 60%, were nephrotic syndrome patients, whereas 40% were CKD patients. Coming to the age distribution in this study, the majority of the patients of nephrotic syndrome belong to a children 1 to 18-year age group, that is 82.6%, whereas in the CKD population, the majority, that is 46%, belong to adult groups and 43% belong to children group. Coming to other clinical parameters, the majority of the population in both the subset of patients were male. The family history of consanguinity was present in 21% of the patients of nephrotic syndrome, as well as 32% of the patients of chronic kidney disease. The developmental abnormalities were mostly absent in both the subgroup of patients. Renal function tests were normal in 100% of the patients in nephrotic syndrome. However, 35.6% of the patients of CKD had renal dysfunction, majority of them requiring renal replacement therapy. The ultrasound kidney shows normal kidneys in most of the patients of nephrotic syndrome. However, it is normal in 60% patients of chronic kidney disease. Coming to the disease spectrum in nephrotic syndrome, the majority of the patients of nephrotic syndrome patients were SRNS cases, that is 73.9%, followed by 21.7% as infantile onset nephrotic syndrome, followed by 5% as SDNS cases. Coming to the renal histology in these patients of nephrotic syndrome, the predominant histology, that is 56.5% of my patients were MCD, followed by 26.08% as FSGS, followed by 13% as IgM deposit, and followed by 5% as MPGM. Coming to the disease spectrum in CKD, the majority of population of CKD, that is 26% each, were on chronic interstitial nephritis or TMA, followed by 20% as cystic kidney disease, followed by chronic glomerulonephritis in 13%, and lastly, unexplained CKD or CKD-U in 14% of the patients. Coming to the genetic analysis in nephrotic syndrome patients, the important thing to note is that majority, that is 60% of the patients of nephrotic syndrome had abnormal genetics, which included both pathogenic variants and also variants of unknown significance, whereas 40% had normal genetic reports. Histology in this abnormal genetic patients revealed that the majority, that is 57.14%, had MCD and 28.5% has FSGS. Also, out of the abnormal genetic reports, 27.7% of the patients had pathogenic variant, and which were Crrp-B2, NPHS1, LAMB-B2, NPHS2, and CP290 genes. This last gene is responsible for the Joubert syndrome in a child. And 2 patients with primary coenzyme Q10 deficiency with PDSS2 mutations were also identified. and 72.3% has patients had variant of unknown significance. Coming to the genetic analysis in CKD, 53.4% had normal reports. However, 46.6% showed abnormal genetics. In those patients, 28.5% of the patients had pathogenic gene identified, and those were INF2, PKD1, aquaporin 2, and 14.2% of the patients had likely pathogenic variants, which was CLC and KB, and rest 57% of the patients had variants of unknown significance. This is a summary of the study of the two categories of patients. In nephrotic syndrome, pathogenic genes were Crrp2, NPHS1, LAMB2, NPHS2, and CP290. Similarly, in CKD patients, the pathogenic genes were INF2, PKD1, and aquaporin 2. Coming to a comparative analysis between the studies, this study was done on 50 patients, and the mean age was 9.7 years. One study was done by Dr. Anil Vasudevan, who is a pioneer in genetic studies from Karnataka, Bangalore. He had done a study on 25 children, and the mean age was 3.5 years. Similarly, Sinha et al. Study was done on across 12 centers in India, and the Podonet registry study was done on 2,000 patients across 72 centers. The majority of the patients selected everywhere was SRNS or congenital nephrotic syndrome. The important thing to note that this study finds the primary histology as MCD, whereas the other study finds the primary histology as FSGS. And coming to the genetics, mutations were detected in 60% of patients in this study. A similar result of 67% mutations were detected in Sinha et al. Studies, and also in the Podonet registry finds mutations standing at 24% of the patients. Coming to the comparing the study from regarding the genetic analysis in CKD patients, this study found mutations in 42.4% of the patients. Similarly, Connaughton et al. Study found 34% of kidney diseases having undetermined genetic etiology, and in Brookman et al. Study, 63% of patients have genetic diagnosis, the predominantly between PKD1, PKD2 genes or collagen 4A3, A4 genes or EMOD-related genes. Coming to the treatment implications, following the reports of the patient, all the patients were contacted and counseled. However, the few of them agreed to undergo treatment changes, and approximately 19 patients, that is 63.3% of the patients of nephrotic syndrome, treatment modifications are done, and they were advised to continue AC inhibitors and low-dose immunosuppressants. Plan for rituximab was done for few patients, but following the genetic reports, it is still on hold and it is revised. Coming to the conclusion, in the present study, we have shown that 60% of congenital nephrotic syndrome patients have genetic mutations, and these children do not respond to immunosuppression, and thus genetic analysis may help in avoiding unnecessary use of severe immunosuppression in these patients and saving them from the unnecessary side effects of these drugs. And also in CKD, genetic mutations are seen in 42.4%, as many of the genetic disease may recur post-renal transplant. Pre-transplant genetic diagnosis may help in planning appropriate management. The limitations of this study were it was a small sample size and it is still an ongoing project. Only monogenic defects were studied, and other things like telomere length or mitochondrial variations or copy number variations were not studied. Before concluding my talk, I would like to stress upon two important factors, that is education of health professional and genetic literacy, that in this NGS era, implementation of genomic studies into clinical applications requires that the clinicians are sufficiently versed in genetics and genomics to prevent misunderstanding and misusing of results. And since genetic testing provides us with massive amount of sequence data, the challenges of such testing should also be aware of, and the clinical validity, that whether the results are of consistent clinical significance, and the clinical utility, that whether knowledge of the results is likely to benefit the patient, needs to be understood properly. In this NGS era, the role of genetic counseling has pivotal importance, and the genetic counseling prior to testing, expectations from the test, limitations of the chosen genetic test, and the importance of variants of unknown significance and secondary finding should be discussed in detail with the patient and the family members. This test also benefits us by providing a timely genetic diagnosis and active clinical management. Like if patients of nephrotic syndrome have WT1 gene mutation, we can go for early testing of Wilms tumor or advice for ultrasound abdomen to look out early gonadotropin features. And besides this, ethical and emotional consideration should also be addressed in these patients as well as their family members. These are my references. And I would like to conclude my talk. And before that, I would like to thank the WIN organizers and committee members again. And also, I would like to thank my respected HOD Madam, Dr. Manisha Sahai, Dr. Kiran Mai, Dr. Anuradha Madam, and Dr. Rama Madam for their constant support and guidance in our department and hospital. Thank you.
Over to the chairpersons.
Yeah, thank you, Kajri. It was a nice presentation. I just wanted to know that have you had any chance of using rituximab in any of these patients, and what was the response?
Yes, madam. A few patients actually we advise for testing after the patient had received rituximab, because few have already been steroid resistant. We had used CNIs and we have again used rituximab, and after the non-responsiveness only we have advised for counseling in these patients. And majority, and we have done 3-4 patients like this, madam, and majority of them has come positive. After that we have discontinued rituximab dose and have kept them on AC inhibitors and low dose immunosuppressants like low dose steroids, and their reports are doing fine, madam. They have no, at least the features of steroid toxicities are, we can avoid them.
Thank you. Thank you.
Just to add to your question, Shaista, just to add to answer what Kajri has given. See, this is a preliminary work which is being done, and we have to do a lot more, and it's an ongoing project. So this is a preliminary experience of around 50 patients which we have shared. So till now, we were using all modalities of therapy and then trying to get a genetic test done. I think that is not correct. When we have a high degree of suspicion, as Kajri pointed out, steroid-resistant nephrotic syndrome, or you have congenital nephrotic syndrome or a family history, or syndromic. Always look for syndromic children in case of nephrotic. And CKD, again, syndromic, family history, or if you are planning for a transplant and you do not have a clear-cut etiology at all. So probably those are the sectors we need to focus on. Otherwise, again, the problem with genetic testing is there is just too much data, and just interpreting that data becomes a problem. So this is a preliminary study, and I think now the results have shown that it's better we do it upfront rather than subjecting the child to toxic therapies and then doing it just to prove the diagnosis.
Just a small question: how much is the charge of doing this?
So as of now, we are doing it free of cost as a part of the project. So that is presently going on, and it's an ongoing project. But the thing is, genetic, you rightly asked that it comes at a cost. So initially they were charging 30,000. Now it's come down to 20,000. And then if you can have a collaboration, they will do it for around 15,000 also. So it depends, and what type of genetic test you ask for is also important. So if you can ask for a clinical exome or a whole genome, so we should know what tests to ask for, and we can get the required information with a smaller genetic test as well. So commercially also, like outside also, I'm able to get it done for 12,000 rupees. But otherwise, as of now, in Osmania, we are doing it as a part of the project.
Okay, I'd like to put my comment. Am I audible?
Yes, madam.
Yeah, so thank you, Dr. Kajri, for your very good presentation. And, working in a government hospital and where there is no pediatric nephrology department, even I do see a lot of patients with nephrotic syndrome, making a diagnosis of steroid-resistant nephrotic syndrome. And at a time comes when we need to do a genetic testing. And like Dr. Manisha said, it is very difficult in doing a genetic testing because it's very expensive. I have called up 2-3 national labs and asked them the price. It was more than 20,000, 25,000. So working in a government medical college, it's very difficult for your patients to ask them to get a genetic testing done. Obviously, your diagnosis should be more of your clinically based, and then you should know when to suspect the patient is having a genetic disease. Secondly, I'd like to add that regarding the cost, it was been discussed. I'd like to ask, how many patients or families of ADPKD, of SLE lupus nephritis, of IgA nephropathy have you seen running in the family as a genetic disease? Do you all very commonly see in your part of India?
Madam, actually in ADPKD patients, all CKD patients who have clear-cut clinical diagnosis, madam, we have not done genetic testing. Only patients of adult CKD with atypical features like ADPKD patients who patient had early onset of renal disease.
I'm not asking about, yeah, I'm not asking about the genetic testing being done. I'm asking you, how many patients have you all seen ADPKD patients? It's because it's very common over here. In Assam, I have seen so many families, ADPKD families, right? So is it very common in the south as well?
Yes, madam.
Yes, ADPKD is quite common. ADPKD is quite common in south as well. And regarding the SLE running in, families, that is not that common, but we do have cases where the mother, daughter, they also have SLE. So though it's not as common as ADPKD, we do have, familial as well.
What about IgA nephropathy?
Yeah, IgA nephropathy also. But though family history has been described, and we have a huge volume of glomerular disease, OP, and we've done a lot of work on IgA nephropathy. However, genetic, this thing is not very common in IgA nephropathy, at least in our parts of the country. SLE, occasional, somewhere in between. ADPKD disease is quite common.
Manisha, one question that I would like to ask. How do you account that 60% of your cases were minimal change?
Yes, ma'am. So
yes, madam.
Some of them might have been missed FSGS because that may be one of the answers. And the thing is, madam, it is a small sample size. It's just 50 people. So we cannot comment. The only thing is probably, in that 50 samples, we had more of minimal change. Some of them might have been FSGS for all we know. So, and the thing is, the patients who consented to do the test. So there are a lot of factors which influence the inclusion in this patient. So that question, whether MCD has more genetic problems or FSGS, can be answered only if you have a large data, for example, that coordinate registry, where you have thousands and thousands of patients.
But
so
as of now, you have done genetic study only in patients who are steroid non-responsive.
Yes, so steroid resistant nephrotic syndrome. So that is another important point, that even minimal change disease, 7% are primary steroid non-responders as well. But probably in our study, the number of those patients is higher. It's a skewed data what we have, but this is what we found. So I think, the message is, we are not saying we don't want the take home from the study to be that MCD has more genetic abnormalities than FSGS. That may be a problem or limitation of the study being a small sample size. We are now going on collecting the other data as well, and we will come out with figures later on. So that's not the message. The message what needs to go is, you should have a high index of suspicion. Don't test all nephrotic syndromes. Definitely that's not the message, but the ones which satisfy those 5 criteria which Kajuri mentioned, and CKD, again, where you have a family history, undetermined etiology, or you have syndromic presentation, keep genetic tests at the back of your mind. Should be done. And regarding the cost, long term, see if you are exposing a child to rituximab and CNI and whatnot over long term,
child will be benefited.
See, 12,000 rupees at the beginning when you have a strong suspicion. If you counsel the family, many of them would want to pay and get it done. Because even when we are talking about 4 doses of rituximab, that's expensive. CNIs are expensive. So probably, that would be the way to go.
Yeah, and the message. I'd like to put my experience as well. Many a times we have made diagnosis of MCD. Put the patient on steroid, patient not responding, termed as SRNS, okay? And then when we had done a biopsy in those patients, a repeat biopsy did show FSGS. I cannot tell you how many, the exact percentage or the numbers of patients, but then in the initial biopsy, the FSGS was missed out.
Yeah, and the message should also go, Manisha, that if somebody is steroid non-responsive, as you said, rituximab is not a cheap drug. And we know that children who are steroid resistant, may not respond to rituximab. So I think it's better, and the same cost you can get a genetic testing done.
Absolutely, ma'am. And then suppose you have, for example, that coenzyme Q10. So that is eminently treatable. And instead of just filing the child with steroids, I mean, it could be easily treated. So those things are also picked up. So I think it's very important. If we think, if we were to be the parents of such a child and if counseled properly, probably we would be interested in getting the genetic testing done. And the cost of genetic testing is coming down. The more and more people are using it, it's coming down. So I think it's worthwhile.
I would like to focus on CKD with atypical HUS, since you have done so patients. Just now we are talking about the positive testing report coming as positive. Now, have you come across in so many groups which are studied that you have CKD, which was suspected as atypical HUS and TMA? All genetic testings are negative, and you the transplant, but you are landed up with recurrence. Have you ever landed?
Yes, ma'am. So we have burnt our fingers with one case. So that's you raise a very pertinent point. And the thing is, genetic testing, again, there are limitations. There are types of genetic testing. And then you have, for example, HUS, especially copy number variations. They are not picked up by your routine genetic testing. Again, you have multiplex ligation assays, probe ligation assays. So you have to use that technology to, get hold of all the genetic mutations. So the thing is, if we ask for a gene panel for atypical HUS, it doesn't include some of these. Routine gene panel, it will look at the factor H, factor I, factor B, but some of the things are not included in the panel. One specific thing, for example, is copy number variation. So we did a transplant, like we ruled out everything, and then we did a transplant and had a recurrence of biopsy-proven recurrence post-transplant. And then later on, on further analysis and discussion with the other people, we realized that we had missed looking at the copy number variations. So as Kajri was telling in the limitations of genetic analysis, we have a lot to learn. So first thing, we should have a lot of genetic database available. Then we should have comparative database all over India about genetics in our population to find out what is significant, what is not significant. And one atypical HUS, one important thing is we have to look for copy number variations, which we don't in a routine genetic panel. So I think it's very important, because no point in doing a transplant and having a recurrence after excluding whatever we tried doing by a genetic panel. So we need to be, as Kajri said, genetic hygiene or genetic scientific knowledge is important. And we, on top of it, now we have another emerging entity, VUS, variant of uncertain significance. So you have classifications of the genetic results. When you start getting the results, initially you are so enthusiastic, okay, fine, you have finally come to a diagnosis. But again, genetic testing is another tool in the armamentarium. It's not the final diagnosis. You have to take it along with histology, clinical profile, syndrome, so many things. Because in genetic analysis, you have criteria. So if you have pathogenic, then it's fine. You have likely pathogenic, that also is fine. Then you have benign, you are safe. Likely benign, you are safe. But the middle category, VUS, is variant of uncertain significance. So you are confused, the family is confused, and some of the educated people, they keep on coming back and asking, what do we do with this VUS? So VUS, again, you have to test the parents as well. And then you do something called familial aggregation analysis, and then later on you do an in silico analysis. In silico analysis means that you have computer database. So you screen for the same genetic mutations throughout the world. In India, we have started doing in silico analysis, but the database itself is poor. So all these variants, what are being done by all of us, the reports are being captured and they are adding to the Indian database. So probably we'll have more meaningful results in the future. So it's not so simple. We are at the beginning step. We have just made a start.
Yeah, may I burnt my finger also.
Madam, sorry to interrupt. Thanks so much for the discussion. I think we have an interesting pre-Congress workshop coming up in the Win Icon in the next month. Shortly, I'm waiting for the enhanced discussion. I invite everybody to be part of that program. Since we are running short of time and we have 2 more programs to go ahead with and the speakers are waiting, I thank the chairpersons. Over to Anuradha for the conduct of the subsequent session.
With no further more questions, let's move on to the next session. I invite the chairpersons for the session, Dr. Namrata Rao, Ram Manohar Lohia Hospital, Lucknow, Dr. Topti Mukherjee, Manipal Hospital, Bangalore, Dr. Preeti Meena, Assistant Professor Nephrology from Bhubaneswar. So over to the chairpersons.
Yeah, Tapati ma'am, I guess you can start.
You have to unmute, madam. You have to unmute.
Okay, I'm sorry. Am I audible?
Yes, ma'am. Yes, yes.
Good evening, everybody, and thank you for inviting me to chair this session. First of all, congratulations to the Telangana state for doing such a wonderful, exemplary job in moving the Women in Nephrology Forum ahead. I think you stand an example, a good example for all of us in other states to move forward. And as Dr. Kiranmai said in the beginning, that there'll be more and more women nephrologists in the country. Probably there'll be a time when we start congratulating the men for pursuing nephrology and inviting them for a guest lecture. So I look forward to many more meetings here, many more academic discussions. And over to Dr. Namrata and Dr. Priya John.
Thank you, dear chairpersons. So I know it is Sunday evening, so I don't want to delay further. So this is I'm talking on behalf of WIN-TS. What is our way forward? How do we want to take it forward? So when I started pondering about why we need to have so many women chapters, so I just look back into the literature, how it started and all. So this is the image I found in, this is actually the image taken from ACKD journal, which is actually engraving found in Pierpont Morgan Library in New York, which shows the art of personification of medicine. But the fact that it is predicted, it is projected, or it is engraved as a form of in the form of a woman. This shows a woman examining the urine in a matula. So it means that probably in the 15th century and in the times of medieval times and Renaissance time, the female physicians existed. So since many ages, the female physicians did exist, but then it probably took a lot of time and takes a lot of time for women to advance in their respective career and field. So when I was just thinking why, what are the barriers? Are there any barriers to women advancement as a physician and as a nephrologist? So I found that before that, I would like to also I thought about this, that I searched the literature and found that how it started medicine, how women started off in medicine. So the first woman who studied medicine was as a part of a prank and not as a part of scholarly merit. So this happened in 1847, where Dr. Elizabeth Blackwell was selected as a medical student into the Geneva Medical College, and it was upon it was upon by the lot of 150 male students. So they never thought that a female would come and take up this medical college. But then that she turned up, and then she was accepted by them, and then they were certainly surprised when she arrived on the campus and did further studies. And that is the beginning of a course of medicine for women. So when I started pondering about what are the barriers to women advancement in nephrology, I found these three factors as the main three factors responsible are the lack of female leadership, probably, lack of female mentorship, and the personal goals we always encounter at each level. So, and I think women tend to take a different part to the leadership when compared to men. Women's leadership styles, they tend to be more collaborative and more inclusive, and they don't quit in the face of adversity there. But then there is always a pervasive bias in medicine with both associating men with science. So for example, I'll tell you that since the inception of American Society of Nephrology, we have had around 51 presidents so far, 51 male presidents and only 4 female presidents, including Dr. Susan Quagwin, who is the present American ASN president. And coming to Indian Society of Nephrology, International Society of Nephrology, we have only two females representing that position when compared to 24 male presidents. And Indian Society of Nephrology, we have had 2 women nephrologists, Dr. Vidya Acharya and Dr. Anuradha Raman, presiding that position. So it is the women are not being offered that leadership positions. And there is this association, European Renal Association, who never had a woman president so far. Though we see that career progression of women in medicine, it continues to improve, they're still underrepresented. I think this matters a lot because women who frames policies would better understand the person, the females better, so that they can frame policies which can more flexible and more mentoring to the women. And coming to the lack of mentorship, I think implementation of formal mentor programs and systematization of achievement and flexible leadership training and roles, it helps a long way for the budding women nephrologists who in turn can shape future generation. As we all know, mentoring can contribute to the engagement, motivation, well-being, career mobility, satisfaction, and leadership capacity of both mentees and mentors. So mentorship, I feel it's a very important part, and which is not much seen during our DM curriculum or DNB curriculum. So I think this has to be enhanced. And coming to the personal goals, these personal goals are never mentioned as for a male, but then we encounter a lot of personal goals, and balancing work life is especially difficult for us, and surprisingly it is universal. It is there everywhere. And for example, having a baby during training is fraught with many logistic challenges, and returning to work after having a child raises further barriers. So I think all this are certain barriers to women advancement, but we have many things which will many people who are motivating and instigating all of us to get advanced in our respective careers. So I also thought, like, do women physicians lag as such in any aspect of their career? Yes, probably partly yes, because I think we all believe this advancement within a medical career relies on continuing professional development, networking, and academic achievement. And I feel we always face certain obstacles and hurdles in continuing our medical education or networking or academic achievement. Like, for example, we always think about a lot of things when to attend a conference or to attend a fellowship or to do anything as a female. So for example, I'll tell about myself. I was interested in interventional nephrology. Interventional nephrology is something which has driven me towards nephrology. But then even apart from the skills which I've learned during my DM program, I never got an opportunity, in the sense I never took time to chisel my interventional nephrology skills, though I'm interested. So there are a lot of personal things which come in the way. So why win Telangana state chapter? So in the recent times, there has been a global emphasis of women in the leadership, and in the social media, we see a lot of things happening. And American Society of Nephrology current president, Dr. Susan Pagwin, is a very inspirational lady and very motivating to all the women nephrologists there. And the work she does, it's just astonishing and motivating. And WIN TS has taken its inception with the encouragement and inspiration from WIN India. WIN India, as we have seen and we have noticed, that it has spread its wings across the global platform within just a span of 1 year. So that is one thing which motivates us to take up this state chapters and to do a work more at the state level, to reach to the community level, so that we would address the issues both at the patient level, at the physician level too. And we all believe that change doesn't happen overnight. So we believe that working together, it is possible to achieve a better balance within our profession, which will be beneficial to both men and women, and to our patients and to our patients. So the way forward, I would like to see our WIN TS as going forward like this. Our mission is mainly to foster an ambience of advancements in academic and research. And as I see, our vision is to collaborate, network, and work across the barriers to provide an niche for women in leadership and research, and to work towards generating equitable access to generating to kidney care, more so to the women. This is to be done at the community level. So regarding raising awareness regarding the patient, regarding the kidney diseases, regarding the kidney diseases. And our goals, provision of the physician skill set. So nephrologists have we have acquired certain skill sets, but then we need to chisel them and get updated there. So probably we would work towards having workshops which would give us a platform to improve our skill set. And increased focus on upstream kidney health at the community level or the patient level by raising awareness about kidney health and awareness more regarding organ donation. And we believe that the key to success is strengthening each other and reaching out to new avenues of learning across the roadblocks we face. So coming to the WIN-TS way forward, we were thinking about having all this program. These are few charted out ideas. So we thought we'll start off having a website for our for WIN-TS, so that we would update our events and then also put our webinars, whatever we are going to do, as an archive there, so that it is viewable and it is viewable. So we're planning for to have a website for our council, and also followed by e-journal, which probably gives a chance to the residents to have their own publication, which will definitely give them confidence to go to go out on a national platform. And webinars, we believe that COVID era has taught us that webinars are definitely help us reach across the international platform, to listen to the wonderful speakers we otherwise would not probably have a chance to listen to them. So webinars, I think we're planning to have webinars with collaboration with the various societies. So that is still in the process. So we were thinking of quarterly webinars with various societies. And as WIN India is doing a tweet chat, we can have a similar program like that at the state level tweet chat. We have had second tweet chat at WIN India recently, and that has gone that was very useful one. So we can have a similar thing for WIN-TS also. And we can have something like Rare Case Club, wherein we can have as more a platform to the residents. Actually, they can have discussions with regards to the rare cases. They can have the presentation, which is something similar to everyday case nephrology we have every once monthly Thursday. So there's some similar to that. We can have this. And I thought this podcasts are useful, especially if done at vernacular level, which can be more of patient centric, would be more helpful. So doing some podcast which can be useful for the physicians as well, but then doing it something in vernacular and reaching out to the community level, that would probably help in raising awareness about kidney diseases, more centered towards women diseases. And we can have second monthly or a quarterly journal club. We have had many journal clubs like similar to NephJC. We have one there, and the certain other things. So we can have a similar journal club more for the more by the residents and for the residents. So something like that can be planned. And a resident dialogue, I thought this can be a blog or something like a blog, better for the residents and by the residents. So this, I think, would help them improve their writing skills also, which would definitely give them confidence as they pass out as a resident and go on to practice as a nephrologist. So these are certain things we have planned. And so thank you. So we believe that leadership and learning are indispensable to each other, as quoted by John F. Kennedy. And we look forward to your valuable inputs. Yeah, thank you.
Thank you, Dr. Priya. That was very valid points that you have raised. The academic sessions that you have suggested, journals, e-journals, podcasts, yes, definitely they will be of great use to many PGs in nephrology. And when you spoke about the leadership and mentorship part, that also is important, because we as women should be, we should be encouraging our other colleagues and other juniors in the field of medicine, because we see many of them, they do MBBS, they do short jobs here and there, and they leave because of family pressures. I mean, we have to encourage them to pursue their, everything has to be simultaneous. It cannot, neither is less important. We should set an example for the others to pursue a career of their choice.
True, ma'am.
Hi, Dr. Priya.
Hi, Namrata.
It's a pleasure. Yeah, hi. And one of the suggestions was like you have mentor-mentee programs elsewhere too. Especially you can incorporate that for, say, internal medicine residents, because internal medicine or pediatric residents, especially females. You know, I know that slowly nephrology has a lot of women around, but you know, we can always contribute to increasing their numbers. Right. So, you know, you could have some goals that the mentee is looking forward to, say, they're interested in doing research. Are they interested in doing something like, you know, social media? Are they interested in doing, I mean, whatever their clinical interests, so wherever their interests might lie. And you can probably match them to an appropriate mentor. And, you know, that is a stage in which, you know, internal medicine is a time, or nephrology is a time when people are, I mean, women are basically at their most vulnerable. They tend to get married at that time, tend to have kids at that time. It's a very difficult phase out there. And, you know, women need to support each other in that phase. Most women take into leadership roles much later than men correspondingly. I mean, any of our stalwart women that we have here, they're all probably just still 5 years behind their male counterparts, in spite of having probably a much higher IQ, probably being there, you know. But still, that's because, you know, we have not had so much support system in and around them. So it would be very good to have a mentor-mentee program also. Another thing that I had a suggestion for was that should have some, you know, academic side to this. Say we develop registries for the WIN as such. I mean, you know, WIN India per se, you could have registries for CKD women with, like, say, fertility issues, psychiatric issues, osteoporosis, anything. I mean, menstrual issues. You name it, and then women with CKD are a particularly disadvantaged population in India overall. So, you know, I mean, we could have nationwide registries and probably some meetings to discuss what kind of data has accumulated in the registry and so on. We have the power to do a lot more for women with CKD, say pregnancy, TMA, so many subgroups of patients who are especially disadvantaged in India. So that was another suggestion for WIN and maybe WIN TS too. Yeah.
Also,
Thank you for the
like you
opportunity.
suggested, a CKD registry, a burnout, female burnout registry would also be helpful, because the caregiver of a male patient who is a female, or definitely there's a huge implication compared to a male who is a caregiver.
So
in our
thank you. I would just cut in here because I can't restrain myself. So you'll be happy to know, Dr. Namrata and Dr. Topoti, we are starting the WIN registry on 12th July. I mean, if all agree, we'll be, I mean, already the registry is in place. The platform has been developed and everything is in place, and the training session would start from next week. So we will be sending the training link to all, and in that you can fill the data, and we can have parallel works on different areas of interest. And Dr. Topoti has added another, dimension. That's an excellent point. So if you can make a basic pro forma of that we submit, and that also would be captured, and all of us would fill data in that. So the beauty of this registry would be that you would be able to collect data on so many diseases together. You can use it for your day-to-day practice, and simultaneously the data gets encaptured in the registry. So I think that we'll be announcing soon, and probably next week we are trying to have the training workshop for all WIN people who have registered. So this would be unique. We'll be concentrating on women-related issues. Thank you.
Yes, ma'am. Also, we could have regular discussions on these fora so that we know what kind of data is being collected, because usually starting a registry is a big hurdle, but then keeping them on and, you know, trying to continue the work into the years to come, and additions as they keep coming on, fine tuning, that would take a few months to years. So I would just suggest, ma'am, if you could include, say, a registry based discussion for, say, at least 5 minutes of any forum that WIN, you know, starts in the future.
That's an excellent suggestion, Namrata. We'll keep that in mind. So once it starts, we'll whatever meeting we have, we'll have updates. Where are we? So believe me, I fully understand the problems of sustainability in India, the problems of egos and all those things. We are women, we are different than men, and we will do it. With all of us together as a team, we will do it. Okay. Yeah, but
True,
thank
ma'am.
you
And
for
also ma'am, and also as a side, we all, I mean, many of us, especially younger nephrologists than me, I would say, are probably in centers where sample collection, sample storage, and a number of other things are still a big problem. Like not everybody has an access in door to a -90 refrigerator and other things, which are all things which I felt after 5 years of practice, I had learned I should have done this for, that particular cohort or something like that. This is where again the mentors are obviously likely to help because they are all women who have like seen this all over in a process. And like whenever a new registry starts, maybe at least a subsection of those patients, if they have their samples stored, the studies will keep coming on from it.
Absolutely. So that's called a
Yes, ma'am.
biorepository, and we are
Yes, ma'am.
incorporating that as well. So all
great,
suggestions are excellent, Namrata, and we'll move forward with suggestions and input.
Thank you, ma'am.
The only thing is
Thank
that we have to keep the tempo going and not get burnt out, as Dr. Mukherjee pointed out, right? So
Yes,
thank you.
I think thanks Namrata, thanks for the inputs, and thanks Manisha for the timely inputs. I request Anuradha to go ahead with the next session.
Yes, ma'am. Now we have an interactive session with Win India and Win Telangana State. And to moderate the session, we have with us Dr. Divya Bajpai, who is an Associate Professor Chem Mumbai from Mumbai, Dr. Smriti, Senior Consultant Nephrologist, NCR Delhi, and Dr. Ishita Tiwari, Consultant Nephrologist from Indore. Over to the chairpersons.
Thank you, Dr. Anuradha. I'm very happy to be here with my fellow friends, Smriti and Isha. They are very close friends. We have worked together on many platforms. And first of all, congratulations from all three of us to the complete team of Win Telangana. It's really inspirational, and you have set a bar really high. I have been attending the whole program. It was a wonderful program. The data which was presented, it was like world-class data. It doesn't look like a small kind of a data. So congratulations to all of you. So Smriti, you want to say a few words, and then we can take if there are any questions from the WinTS team.
I would thank you everyone for firstly inviting us. We have been associated with WIN for a while, and after having spoken to Dr. Urmila and then being part of this platform, I realized it's been greatly motivational for me personally to see so many examples of great female leaders. Like we were just talking about mentorship programs. It is really motivational for comparatively younger nephrologists like us to know that it can be done and to give us like a guidance in that sense. And today's program was excellent. We are very happy to have Dr. Urmila in Delhi now, and we hopefully will be starting with our Delhi NCR chapter 2 soon. Yes. So I think Dr. Isha, would you like to say a few words?
So good evening, everybody. This is Dr. Isha. I'm from MP, but I'm really and extremely close to Telangana State because I've spent 3 very precious years of my life learning live and learning nephrology here at Nizam's Institute. So I would say that, I have a dil ka rishta or rather a kidney ka rishta with Telangana State, and all my good wishes are always with everybody. From whatever I've learned from my role models, right from Dr. Swanlata ma'am, from Manjusha ma'am, Manisha ma'am, everybody there in Telangana, I think I'll always imbibe it and it will be etched in my memory forever.
Yeah.
Dr. Divya?
I think Dr. Divya's camera is not functioning properly. So we had gotten a few questions from the team, Telangana team, on what are the points that they would like to talk about. So there were a couple of questions. Maybe I'll start till Dr. Divya joins back. One of the questions that came to us was about gender pay gap and how, as female doctors coming into private practice, can we basically negotiate better, and how do we reduce the pay gap? So from my little bit personal experience that I have had from shifting from a government to a private setup, I would say a few points that I would like to share would be that firstly, knowledge is power. So when we shift out into the private sector, it's very important to know, don't be scared about talking about money. Talk to your predecessors, talk to your colleagues, talk to people who are maybe 2-3 years above you and ask them about what are their pays, what is the kind of structure that they've gotten into. It's very important because when you walk into private setups, there are fixed pay salaries, there are minimum guarantees with incentives, there are team-based practices, there are individual practices. So there are a plethora of options available. It's best to know what the current scales are, and also in the future when you talk about promotions, whether it's going to be a fixed promotion, whether it's going to be based on some incentives, do they or do they not recognize some programs, like from a couple of people I've spoken to in Gujarat, in institutes like STIMS, they also take into account the lectures you take, the academic researches that you do, the papers that you publish, all of that into your promotions. So again, coming to the point that you should know what you're getting into by talking to as many people as possible. Female mentors are, of course, the best that I think we can provide through WIN. But even if not that, talk to male colleagues and seniors who are passed through the institutes or working in the same area. And then maybe when you go for the negotiation, don't ever, I think it's good to show leadership skills in terms of taking on more responsibility. So going and saying yes. So like, for example, when I went into private setup, I was a little scared about doing interventional nephrology because in government setups, you have a lot of backup support, which you might not get in smaller centers. But take the initiative, don't be scared, do those things because it kind of sets you apart from other people. It's very important to stand out. So if you are willing, go ahead, do COMCATs, do difficult cases, do biopsies, learn fistulas from colleagues, from CTBS surgeons, vascular people. And like that also adds on to the income that you bring into the department, which you can later use to negotiate higher pays. So I guess those are the few pointers that I would say. I'm happy to take on any questions later if someone wants to talk about it. And the second thing that I think I wanted to talk about was exchange programs. I had discussed this with Dr. Urmila much before also, especially for interventional nephrology. If there are people who have got maybe initiated into it in their training days, but have not been able to do it for whatever reason later on, or would like to set up these programs, because it's very important if you're running a dialysis center to also have a good interventional nephrology program simultaneously for all kind of vascular accesses, fistulas, difficult COMCATs for patients with failed fistulas. And maybe like in Delhi, I know I am doing it, Dr. Lavi is doing it in Max, and 2-3 other people who are actively doing interventional nephrology. We can have exchange programs who, if they want to come work with us for a few months, and then maybe vice versa for some other programs. Dr. Divya, would you like to take on from here?
Yeah, definitely. This is a very, very important thing. This is one way in which WIN TS can constructively collaborate with other WIN chapters or WIN in general, that we can have very supportive programs. Like there are almost all the centers, like the good centers in nephrology, they have few strong points and they lack in few points. Like some centers do lots of ABO incompatible, lots of deceased donor, lots of transplant. Other centers do lots of intervention. Some have a big glomerular disease thing, like CMC has this with Dr. Saxena. So there are things which are strong points of various centers. If we can if we can exchange our via the students, if we can exchange students and our ideas, it will be a win-win for everyone. Dr. Priya, are there any questions from your side, or we can go ahead giving pointers?
So we have this question from Dr. Deepthi. She's asking, she's one of the executive members.
Dr. Priya John, let Deepthi speak, no? I mean, let them interact. Just another 10 minutes.
Dr. Deepthi?
Right? Deepthi, can you please interact? Dr. Deepthi, are you here?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Please pose your question. Please.
Thank you for giving me this opportunity, ma'am. I'm Dr. Deepthi, consultant nephrologist in ESI Hospital. It is one of the tertiary care hospital with lots of patients with great funds, actually. So my question is, how do you coordinate the research work, academic work, along with the clinical work? Do we need to upgrade any tools in this aspect?
Yeah, thank you. Thank you for that question. And congratulations, Dr. Deepti, for being part of this wonderful organization, WinTS. So, first thing first, is it possible? Yes. Is it easy? No. It is difficult. You have to believe it is difficult and take it that way from there. But also remember that nothing worthwhile is actually easy in life. And if someone can do this, it's women who can do, because we are ingrained to do multitasking. Like no one else can do as good multitasking as we can. So you need to believe in yourself. You can very easily coordinate research work, academics, and your clinical practice, either whether you are in private or you are in academic institute. One key thing which has helped me is to keep these three things: clinical practice, research, and academics in harmony. Like they should not be dissociated with each other. So, for example, if you're thinking of a research question, don't think of some exotic thing which goes on, like some exotic new drug or new therapy which goes on in Western world. Think of research question which is directly relevant to your patient which you see day in and day out, their problems, their profile. Do think of stuff like that, which will keep your clinical work and research in hand. Similarly, academics, if you're training someone, some PG student, or you're reading for yourself, read what you have seen the last day in your clinic, something like that. Also, a small thing which has helped, especially my colleagues in private, is habit of counting. Like keep on counting, even if you're counting 2 cases, 3 cases, 4 cases daily. You might think like you just have a handful of IgA today, but over the years, like tens will become hundreds, and then they'll become thousand. So counting today, if you start today, if you do it on a regular basis, it will not become a burden. And having electronic medical records really help. Like you said you are in ESI. I'm not sure, but in Bombay, ESI does give a good electronic medical support. You can have that at your center. That really makes life easy when it comes to data collection. So keeping all of them not dissociated, in harmony, really helps. It is difficult, but it is possible.
Just Divya, just one point to the last sentence you added. So Deepti, in fact, like that registry platform, it's something like that. So if you don't have an EMR at your place, so we will have a common language to talk to each other. The platform is easy, all can fill, and then we can have easy publications, multi-centric data. So many of us are there, women power. You just need to fill and you take a printout of that you give to the patient, because you can use that platform both ways, to generate data as well as go along with your routine practice. So we have customized that data in that manner, so that those people who are in private sector, we can't expect them to see the patient for 10-15 minutes and then keep on doing the data entry. It doesn't work that way. So as Divya said, harmonize and try to have some shortcuts. So here, once you enter the platform, you need not write a paper prescription. Everything along with the generic drug, the trade name of the drug, you will get a printout. At the same time, your data is already there in the system, and it is in that format which can be analyzed both in figures as well as in graphics, and each of us can be a lead in certain area which is unique to our situation. So I think that would be the way to go.
That will be wonderful, madam.
Thank you so much, ma'am. Thank you so much.
Thank you, Divya. We have Dr. Rana Fatima. Are you there?
Good evening. Good evening, everybody. Once again, I thank Dr. Manjusha and Dr. Samantha for giving me this opportunity to be a part of this platform. And this opportunity, I particularly thank my mentors, Dr. Manisha Sahai and Dr. Anuradha. My question to the chairperson is, I have first I'll just explain why I got this question in my mind. Is morning, as I mentioned before, I work in a rural tertiary care center, which is a private medical college. And in the evening, I have my own practice, which is a very peaceful practice. And I have to change my gear once I come in the evening. It's a very comfortable place. But over a period of last 2-3 years, I've noticed the type of practice in the morning is completely different from the evening, which I think many women nephrologists must have also noticed when if they have their own clinics. So I'm approached more by female patients for some not nephrology related problems like UTIs, low back pain, pain abdomen, and certain other issues which they are unable to open up in front of male physicians. And then there I noticed that many women are bearing this, they're having lower urinary tract symptoms, which they are suffering for the last several months to years also. Some women are suffering. And I understand that by good history and doing a simple test like ultrasound abdomen pre-void and post-void residual urine and giving a therapeutic trial, many patients we are able to like manage the symptoms quite significantly. But still there's a big chunk of patients, I can say, who require further urodynamic study. And because I'm in a place, Karimnagar, which is 4 hours drive from Hyderabad, there we don't have urodynamic study, we just have uroflowmetry. So I have to refer the cases to Dr. Sanjay Sinha in Hyderabad. He does very good data. Only is I have to select, patient selection is again important when I send the patients. So many patients are lady patients are reluctant, specifically I'm mentioning about lady patients. They're reluctant to go to Hyderabad. But once they're going and referring, significant, the urodynamic study was worth it, the effort was worth it. We have neurogenic bladder, we have atonic bladders, the things which were not diagnosed before. So my question to a senior nephrologist and other members are, shall we have workshops? Can we arrange workshops for women nephrologists to understand urodynamic study better? And can we ourselves have a separate urodynamic setup? Why I'm saying this is definitely we'll have an edge over men nephrologists. Second thing is we can follow the cases again and again, but these things have to be repeated again. So the female patients who are coming to us for this, they'll be more comfortable. And there are pitfalls when we are doing the urodynamic study. The patients, if they're not comfortable, if they're infection at that time, and the person who's doing the urodynamic study is not connecting with that person, and the other urologists where we have referred, if they're not understanding that, maybe the report may not be up to the mark. So if you have our own, if you have awareness how to do this test, conduct in our own clinics, so it may be giving us edge over men nephrologists, and it is good enough for a practice for female people, patients also, I'm saying.
Yeah, Rana Fatima, I would like to step in. Yes, absolutely. Point is well taken. I think, female urologists are there in Hyderabad. Sarika is there in National Institute of Nephrology, where the urodynamic study is one of the best that is done. As you suggested, definitely on behalf of Win India, on behalf of WinTS, we can conduct workshops so that we ourselves are trained. Of course, Dr. Sanjay Sinha is always there to support us. In fact, he has done earlier special sessions on how to look at urodynamics. I don't know whether you remember it or not. Even in the few of the conferences and fora, Hyderabad Nephrology Fora, he has spoken in the past as well. So if specifically, yes, we can get information and organization of workshops from the female urologists who are available, and we can ourselves get trained as to how to go about it. It's feasible, and it's definitely a good suggestion which can be taken forward on behalf of the chapters and as well as Win India.
Thank you.
Manisha, can I comment, please?
Please, Sonalata.
Yeah. I mean, I don't know whether you have experienced the same. We see a lot of, female urologists now. Every year, you are in our hospital, we see a female joining as a urology resident. So I think, our WIN, we have other, associations also as a part of the associate members. So we can encourage the female urologists to join as a member, and we can, have a networking and trying to find out these solutions. Like we have more networking and more, the experience sharing, and then their services we can utilize academically as well as the clinically. So that
the real
would be
practical solution, madam, to the problem.
Isha, you would like to share your views about this?
I 100% agree with Dr. Rana, because I am a nephrologist and so is my husband. We both, sit in two separate rooms which are 6 feet apart. And what I experience here is that most of the times the female patients, they will selectively come to me even if it is his OPD day. So that way, yes, the female patients definitely are more comfortable in sharing things like LUTs with us. And if at all gastroenterologists can do endoscopy, if cardiologists can do interventional nephrology, we can definitely foray into things like cystoscopy and urodynamic studies, because definitely it will be of great help to our patients. Also here in Indore, in MP for that matter, we don't have many female urologists. So learning UDS would be a great edge to all of us.
Thank you, Isha, and thank you, Divya. So we have Dr. Rama. She has a question.
Hi, everyone. Good evening. I'm Dr. Rama. I'm Assistant Professor Nephrology at Osmania Medical College. My question is, while we will continue to collaborate on academic issues, what will be the non-academic areas of collaboration between WIN-TS and WIN-India?
So I'll just step in for, like we've already mentioned, at least for the intervention part of it, like if anybody wants some practical hands-on knowledge, I think we can come up with an exchange program for the intervention nephrology part, be it POMCAT, be it exposure to fistulas. And then if they like to pursue it further, then maybe later on we'll have a better scenario, like a program that we can actually develop for that at least. For other pointers, Dr. Divya, Dr. Isha?
No,
I would
Smriti,
say
like,
that apart
Yes,
from
yeah, can I comment here, please?
Yes, ma'am.
I think she's commenting about the non-academic part. Yes, Rama? I mean, did I get you right?
Yes, ma'am. Yes.
Yeah, in fact, I was also thinking of the same for the Hyderabad Nephrology Forum. Why should not we have a non-academic
Yes,
clubs?
madam. The last
Like,
session was a big
the
success,
fitness or the, some cultural. So it's
Yes.
always better to have, yesterday we are talking about the balancing, work-life balance. So even in the
Work-life
work,
balance,
we can have a non-academic
financial
thing.
literacy.
Actually,
Yes.
exactly.
Yes, that would be great.
So, yeah, the last session at Hyderabad Nephrology Forum was a big hit. The financial advice
Exactly,
for the
financial.
nephrologists. So
Yes.
really, I mean, it was an
That's only we have
eye-opener.
taken a clue, and then we thought of having a non-academic clubs. So,
Yes, madam. I think they should be
Rama,
clubbed
if you're
along with
interested, we'll
academic
make you as one of the, member of this non-academic club, both for WIN and as well as for Hyderabad Nephrology Forum.
Right, ma'am.
Very much needed, especially for women. Especially financial literacy is like it is the need of the hour.
Yes, madam. And also career guidance, like you said rightly, gender pay disparity between men and women nephrologists, all those issues, how to handle.
I think creating awareness and having a support group with whom we can at least discuss these issues is also a big support factor. Like, I mean, for most of us, I think we didn't even know who to talk to about finance, about negotiating. So I guess having a support group in that sense would be great.
Yes, ma'am. Also,
I would like to step in at this point.
Yes.
Rama, I would like to step in at this point. So I think non-academic issues have taken a little, little importance, just not the academics, especially when women are there in the field, as has been discussed successfully yesterday in the tweet chat. It's
Right.
difficult for a woman to have a balance between the work mode as well as the life mode. Having said that, I think we should have from the patient perspectives and certain advocacy areas, which will be again non-academic, which can be done in coordination amongst the chapters of the central as well as the states. And from the doctor's perspective, yes, lots of things are there, starting from finances to mental balance to psychological counseling to cosmetology to what not we can speak. So women, when they're multitasking, they're also multi-dimensional and they have also got multi-requirements. So we as being women, I think we do know what our requirements are. I think if we can get, when we can get associated with academic societies, we can as well get associated with non-academic societies, which can put in or instill in us certain non-academic things which will make us more complete person and more holistic person, not just doctor, but a holistic woman whom we are looking at. So I think the point is well driven and point is well taken. Of course, we will try to plan from WIN-TS point of view as well as from WIN-India point of view. And so we will try to take it forward under the guidance of everyone, whoever is interested.
Yes, ma'am. Thank you for the support. Yeah, I think it is much needed too.
Is a need of art. There is no disagreement or confrontation about that aspect. I think we'll take it forward as has been said. Any further questions, Dr. Priya, John, and the chairpersons?
Yeah, we have one. It's from Dr. Lalita. She left the session. So she asked where all should a budding woman nephrologist should focus to shine in future, and how can one contribute to this WIN-TS or WIN-India program?
Yeah, so again, a very pertinent thing, and there are specific things which specific sort of a like advice maybe from what I have gone through and what I have seen people doing for our younger colleagues, younger friends. First of all is it's a very small thing, but you should try to first of all is like you should not try to stop from experimenting and not get intimidated. intimidated, because see, the thing is that you will, when they pass out, they are the youngest in the cadre, whether they're in an academic place or they're in a private practice. There are people who are much more established, much more accomplished than they are. They'll be always around them. So don't feel intimidated, don't feel scared, or don't hesitate to experiment, to try things new. Don't hesitate to take responsibilities. Like you have this WinTS, take new responsibility, new roles, try to do things which you have not done before. Don't hesitate to do that. That is something which will, once it becomes a habit, it will take you forward. Another thing, a practical thing is, I would advise is that try to create a niche for yourself. Try to get into areas which you are genuinely passionate about. Like we were talking about intervention. Someone might be passionate about research in specific areas like onconephrology, lupus, glomerular, dialysis, peritoneal dialysis. You need something to stand out. In today's world, you cannot be with the crowd too much. You need something where you specialize about, like where you can say with authority that you know this topic. You obviously, everyone knows nephrology, but if you choose few areas, you have some in-depth knowledge about that, you do research work in that, then you will be more able to create your ground in that area. So that is one. And the third thing I would like to say is do networking. That is the most important thing in today's world. Networking doesn't even only help you professionally, it also helps you personally. Like sometimes you feel left alone or very lonely in the whole professional circle also. So networking helps you in that time. And this is the best time to do networking, because you have so many things available at your fingertip. When you have just passed out, when you are a budding person, you are not too much ingrained into like lots of responsibilities, so you can venture into various areas. I would like to draw attention to groups like NSMC. NSMC is it's an internship program which gives you which actually opens doors to lots of opportunities like NEFSIM, NEFJC, and there are lots of it. ISN Academy, you can join ISN Education, you can join GLOMCON. All these are web-based training or mentorship program which will help you in professional growth and also help you in networking. So don't try to hesitate, try new things, experiment, do networking, and try to develop your niche area. That's for me. I would love to hear what Isha and Smriti want to say about this.
Yes, I also believe networking really helps. Basically, also a lot of times we are unsure. I think as women also overthink things a lot. We believe that maybe we're not as good at something, because most of the men clearly guys come across are very confident about what they project. And I think they project a sense of confidence that we kind of lack in. And networking, talking to other people, I think kind of helps build that. All the doubts you have about yourself, I think you feel better about it after you network and you realize, yes, almost everyone is on the same plane, everyone is struggling, everyone is learning their job on the job. So that is a very, very good point, I think. Dr. Isha?
Yes, I would say that I absolutely agree with Dr. Divya. We are so better in so many fields as compared to our male counterparts. Coming into presenting things, our sincerity towards work, our dedication, our methodical approach to things. So we should all be consolidating it and having that inner confidence that yes, even if we have just passed out, we have learned so many things which we could be practicing. So yes, not getting intimidated and following whatever we have learned and imbibed it within us in all these years should be our thought process.
Thank you, Isha. Thank you, Divya. And thank you, Smriti. We really enjoyed listening to you. Thank you for answering all the questions.
Thank you for having us.
Yeah, thank you so much. Thank you so much for inviting us.
Thank you, chairpersons.
So, yeah, thank you so much, everyone. I think it's been a really lovable and a very lively event. In fact, every one of us has gained lots of tremendous knowledge. I'm sure everyone is better after this inaugural meet. But having said that, I have a little inputs to the WIN India members. I request, since these state chapters have started forming, I request for the formation of the chapters of Maharashtra, since Divya is here and Dr. Kalpana madam has joined. She's not here right now. And Shruti, she could not join. So all active members of Win India, Maharashtra, Madhya Pradesh, I think Isha is already working it up, and probably they will inaugurate it in last week of this month. And Delhi, I see so many people. And now that the president of WIN has moved to NCR, I think Delhi is more stronger now. And so I request the Delhi people to start their own chapter with 15 to 20 people in the count, as Manisha has been saying. So I think it's time that the Delhi chapter also starts. And Assam, Manjuri has also left. So there are it's definitely significant possibilities and significant opportunities for the state chapters to start, as has been mentioned by Dr. Vimla madam at the outset, that Kerala chapter, which has about 50 plus in number of women nephrologists, has a potential to start a chapter in its own. And of course, the Karnataka Society, whom many of the chairpersons were from today. I request everybody to look into the opportunity, to look into the option or the chance to start their own chapter, so that, as has been mentioned by the WIN TS secretary today, as to how to take it forward. Yes, we need to spread our wings, and then we need to be coordinating, we need to be interacting with each other, so that we excel and scale in a constructive manner, in an optimistic manner, just not nationally. As a team, I think we can project ourselves in an international level in a phenomenal way. We have achieved it at the outset, but as has been emphasized, sustainability is crucial. Sustainability can only come when the torch person carrying can continue the torch carrying, whatever it is. So what we request from the senior group is that we request the younger nephrologists to be active and in all respective chapters, and take forward all the ideas and thoughts that have been put in various dimensions, so that the WIN chapter sustain, and thereby the WIN India sustains in a stronger manner. I thank the senior faculty who have joined, Dr. Vimla madam, Dr. Anuradha madam, Dr. Nandita Chaudhary, despite so many technical challenges, and of course the other chairpersons, Manisha Sahai and Manisha Dasi. So everybody, Dr. Arpana, Dr. Renuka, everybody has joined. In fact, it's been like lovely session today. So I thank everyone from my personal perspective, as well as on behalf of WIN TS, for coming over and speaking to us and sharing your thoughts and guiding us, so that we take this chapter forward and also WIN India forward. Thank you so much. Good night, everyone. Please put in your opinions as well and mail us if you can, and we will go ahead. Thank you so much, everyone.
Thank you, everyone. Excellent. I mean, it's 9:30 and still we are all here. So thank you. And excellent points. I mean, Rana brought up one point, and then, I mean, Divya added to it. And I mean, Rama talked about non-academic. So women, I mean, we just have wings. So I'm so happy to be a part of.
On a closing note, a good event never ends in the world. They take only a pause and keep us waiting for the next. So I would like to thank all the honorable delegates who blessed us with their presence, and I thank the organizers. I thank one and all for making this event successful. Thank you all.
Thank you, and good night, everyone.
Good night.
Thank you all. Thank you very much. Good night.
Good night. Good
Good night, ma'am. Good night. Thank you.
Yeah, thank you. Thank you. Thank you, everyone. Good night.